All right, everyone. I hope everyone is well. Please let me know if you can, hear my voice clearly. Please let me know in that case we can start the session. So we'll be just starting in a minute, and I'm going to share my screen now. Right. Okay. All right. So that is wonderful. Good to have all of you. Good to see all of you. So that is great. Yeah. So you can mention as a loud and clear. Is as mentioned by in military or in armies. It's very common, like using the word loud and clear. If you can see my screen, so if it is loud and clear, please do let me know in the comment section. Actually, great. Okay, that is wonderful. I think I don't need to use a filter monitor, I guess. Yeah. So yeah, because I'm already in my office and studio, so we don't need a virtual background, I think. Yeah, so that's great. No worries, actually. So the previous background was based on some educational platform. We already have a lot of things in our wings, so that's one of the background that I use, actually, like SK Education. Shares Medical Academy is one of those wing, and SK Education is another wing um, we are using nowadays, actually. Yes, so that's like a for overseas education and all these things. Actually, I myself also finished a post graduation recently, so we'll talk about it some other day. Don't worry. I mean, you can search as a SK Education Bangladesh. You'll find more details. All right, we'll come back to that one. Let's focus on why we are here. To solve a lot of recalls, definitely. And yes, so that's the plan, to do a lot of recalls today, actually, right? That's great, actually. So do let me know in the comment section how you all are doing and when is your exam, actually, when you are planning for your exam, to let me know in the comment section. I mean, then we can start the session without any further delay. Great. All right. Different people, I mean, planning something different, I'm sure. Some might be planning March, April, May, June. So that's all of the thing, actually. So those of you are having exam on the March, it's a very good choice joining this batch. April, May, they can also join. Actually, we'll have more time on that one. So that's great, actually. So what type of support we are here to provide you? So that's the thing. Today we're going to solve the March. So we will do a lot of 1 year of recall in this live class. So from March to another upcoming March, we'll be keep solving a lot of recalls. Those of you who have exam on the April and the May, you will also get file supports, actually. All right. So don't worry about that one. So here is the class routine we have so far, as you can see. Let's start with the bottom, first of all. I'm asking one more time again that am I clear? Actually, is it loud and clear, the sound? Because later we will not go for sound checking. So are we loud and clear to start? Great. All right. So I can see a lot of people are commenting loud and clear. So start from the bottom. Okay. What is given in the bottom? Great. Yeah. So that some people don't sleep, you can use drums as well. That's okay. Some animations. Now, in the bottom, if you can see live classes. So as like the live classes I'll be taking like this, and we'll be solving recalls from the March 2023 up to March 2024, the live things we'll be doing. And different people also will have file support. Even if you have an exam on April, you'll have a support group, actually. Okay, so you'll have the support group during the April. If you have a exam on May, there'll be support group for the May people, actually. Okay, so you don't have to worry in that way. Okay, like we keep giving the support group as well for our exam candidates. During exam, we also try to help our candidates at the same time. Okay, I hope this information is clear. Other than that, what you are getting. All right, other than that, you are getting also, many of you have taken admission. We have already transferred the file. So 2023, 22, 21, all those folder and the file together will be given there. If I just show you the distribution of the file just in a second, I'll be just taking a minute to show you the file distribution, how it looks like. All right, so this is the thing. This is how things looks like. So you can see the 4 years. We are talking about 2023, 22, 21, 2020, all this folder, including 2024. I mean, if I include that one, that'll be 5 years nearly, let's say 4 years. So you'll get all this folder. If anyone has taken admission, not getting the file yet, after class today, we will send you definitely, or by tomorrow, we'll send you actually. But most of them has already received the file and folder. So if any folder, for example, if I take a folder, okay, last one was done November 2023. If you click that folder, you see that some files and things are given already. All right, time to time we'll update more on. Then if you say like say other things like October, so October if you have video folder, file folder, so it's given kind of like that actually. You can just go and follow them very easily actually. All right, so that's the thing. One more request to all of you. One more request to all of you. If possible, try use a laptop device. Like I'm using a headphone, I'm using a laptop. If possible, you try to use them. It's much more convenient if you can use a laptop device and things like that. Okay, for the classes, iPhone, iPad. These are sometimes distractor during the classes. Your message comes, WhatsApp comes. This all popped up even in iPad, right? So those are like distractor during the classes. So we have seen those use laptop or desktop these devices during classes or further study, the chances of doing in more better in the exam, because you are trying to study in a mobile, you get distracted, someone close messages, so this thing can happen. Many of the other things is recommended. For example, I'm not sure how many of you use sticky note. Like if I just show you my how my offices looks like see there's like particular few things. It's also something related to sticky notes, I think. So do you use a sticky notes method? I'm not sure, do you use these things or not, a sticky note type of thing? If not, I mean, using this type of sticky notes in the table and the walls can be really, really useful actually. Okay. Keeping a diary for your study. I mean, whenever you will be taking classes, we'll highly recommend, if possible, you keep a diary to write extra note and follow them up. We have also group named Shahriar's AMC guideline group, right? I'm sure everyone is added there. So there's regularly we post recalls, and also you can search a lot of recalls there. Like example with the word GIT, respiratory, you can search a lot of recalls actually, and you can also take preparation from there. This group is made like in 2015, so it's been 7 years. So for 7 year things, we keep posting. So you can find so many things actually. Okay, you can find the so many things there actually. Okay, so that's the thing we are discussing, and I'm going to share my screen again. That recall thing we're bringing now. Yeah, great. So I'm going to share my screen again. I hope you can see me. Great. So here is the thing. Here is the routine again for all of you. This is a second. So I'll just give a little demonstration on that March recall and this, that. A little demonstration on the material, but we'll give you more demonstration also on the next day. So don't worry about that one. We'll give you more demonstration on the next day. So don't worry about that one. All right. So that'll be really great. So second, fifth, eighth, 12th, 19th. So, there's a lot of classes will be live, a lot of type of classes. So up to this March, we have classes on for the April people will be also taking April support group. For the May people, we'll have also May support group. Okay. This is how we'll go on. Great. Now that's the thing. And we'll go and start a lot of file things. So don't worry. You will have a lot of collection on the files and this, that. So don't worry about that one actually. All right. Some people said like in Australia, there can be little issues with the network. I'm not sure about that one, but I believe like as far as the class progresses, your network will be fine actually. Great. So that's the thing. Wonderful. All right. Let's wait 1 minute, guys. And how is your preparation so far? Actually, I'll share my screen again. How is your preparation so far? May I ask, to the dear doctors, how's your preparation so far going? So in that case, please confirm us in the comment section. Please let us know in the comment section, how is your preparation going overall? Yeah, taking a few seconds time, so don't worry about that, guys. Just wait for others to join. Just taking a minute so that everyone joins us. All right, dear doctors. So no problem. I think it's better we do the April one today. March one we'll do soon. Sorry, don't worry. Great. All right. So March one we'll do in the next one. I mean, after little do one to correction on the March file, we'll good to go. So as I mentioned, from the March to March one we just put on the next coming day. We'll do the March actually. I need to do a little bit correction on the March recalls actually. So let's do the April one today, and next day we'll do the March actually, and then followed by. So from March to another March, we'll do a lot of things. So let's keep a copy here actually. Yes. All right. So those of you just now joined, this is your mentor, Dr. Shahriar. We're going to start the session, and we have a recall coming up. We'll do March to another March in the live classes, and the 4 years of the materials and the things which we will definitely give you actually. And as you can see, like the some of the file and the folders, that's how it looks like. Those of you who have taken admission got the files and the folders. Some might be left, we'll send after the class. This is how it looks like. This is how also SMA notes and these things looks like. As you can see, there's so many notes. Also in the folders there is so many files in individual folder. So if you just enter, you'll find them easily. So any folder, if you enter, say, you'll find a lot of folders like that. All right, anything you enter, you'll find the folders and things are given there. All right, so folder files, everything is given as a compilation, and we are also giving you 2023, 22, 2020, and of course 2024. When 2024 classes will start, we'll also start adding them. 2024 exam is not started yet. All right, so that's the thing. 2024 admission, you can leave me an inbox. Okay, someone asked me how to take admission, you can leave me a drop a message. We'll send you the details actually. Make sure you are added to the group. Some of the admission process we can do also tomorrow, so not a problem. So these are the things, and some of the extra and bonus files, and also some of the mocks also given here. We'll also take your mocks in computerized form at the same time, so don't worry about that one. So shall we start, guys? Are you guys ready to start the recalls actually? I mean, some initial introduction and the things. And initially we already asked you, when is your exam and this that, so that's the thing. Great. All right, so we'll give you some extra time after the class, so don't worry. Let's go and start today. Are you guys ready? I mean, you can just bring in the comment section as a ready. I hope you get a little idea about the materials and contents, and next day class will give you details about the materials. Next day class will give you more details seeing about the materials actually, so don't worry about that one. Right, so that is the thing. This is the class routine. This is the class routine. Right, so I'll keep the class routine here. If you want, you can take a picture. We'll be starting in next 15 seconds. All right, guys, you have seen the routine, guys. I will post this routine. Okay, I'll post this routine in our section, so don't worry about that one. I'll post this routine in our section. Great. Let's go and start the session without any further delay. Thank you so much. Okay, so here's the first question for today. I will keep myself in the side, actually, that's okay. Okay, multiple, spider bite, red back spider bite. I mean, in whole 2023, we have seen a lot of time this spider related question come in. See, from the poisoning section, they always try to improvise one to new things. Okay, so that's the thing. So this time, one of the poisoning question that came up is like a spider. Previously, we have seen jellyfish one, right? Jellyfish related, and many things, like snake bite related question often comes. So every year they introduce one of the new one actually. So this time, red spider or spider bite. So red black spider. This one was a highlighting thing of 2023. Those of you who are following the question, they must be knowing it. So red black spider bite with a pain, erythema, blood pressure is like that. So looks like blood pressure is okay because after some bite there can be hypersensitivity or anaphylaxis. Now, coming to this point, what to do next? Fluid, antivenom, or NSAIDs? Now, coming to the very first question, did you really think antivenom is required here? Do you really think antivenom is required here actually? To give something antivenom, actually, there is sign of envenomation is required. Did you know what is the term in envenomation? Envenomation means when there is a snake bite, spider bite, or anything bite. If it starts showing the sign symptom, then it is called in envenomation. So, do we have a sign symptom of envenomation? Like the first thing if we see, do we have a sign symptom of envenomation? So, first of all, I think so. I don't see any sign symptom of envenomation actually. So, in this case, we think so. This can be a case related to what do you think? Will it be related to envenomation? What do you think? Okay, coming to the point. Coming to some of the point. Okay, don't worry about the answer. You know, we can. So, if you see red spider bite, now pain, now erythema, now okay, BP. Now, what are the some sign of the envenomation? We have to look into it. Okay, whatever the some of the sign of envenomation, we have to look into it. Okay, one of the most initial sign of red spider envenomation. Coming to this point, okay, so this is the sometimes MC can be little confusing. These are some of the thing MC can be little confusing sometimes, like some specific condition, some specific thing. Normally we think okay, pain might not be. Normally we think pain might not be, but here this is taken from RSCGP. This is taken from RSCGP, and the very first thing as the envenomation sign they mention, immediate pain at the bite site is a sign of red spider envenomation. See, maybe sometimes snake bites may not be much issue if the pain is there. For a snake bite, we might think neurotoxin, cardiotoxin, those might be sign of envenomation. Pupil changes, more sign. But here, red spider envenomation, the first red flag is a pain at the bite site. Okay, so this is one of the thing. And pain at the bite site and also at the same time erythema. Erythema is normally plus minus, but here erythema is present. So I'll ask you this question again. Is there sign of envenomation present? Okay, let's start with the new year in this way. Sorry about that, guys. Sorry to start the new year in this way. Could have bring a more easy one. So now my question is, so the answer, what do you think? Agreed with that one. It's a bamboo. Sometimes we call the word bamboo means actually in our country, it's we call it bash. It means actually what you were expecting, it does not happen. Okay, so opposite thing happened actually. So this is you are expecting NSAID because NSAID is a provision, but you know if sign of envenomation present, we give it first actually the main thing. If sign of envenomation not present, if just in a spider bite or nothing much really happens, only erythema, no pain, only erythema, no pain, then I would have give what NSAID. If pain is not present, only erythema present, then what do you think? If pain is not there, you know, it doesn't matter much if erythema is present or not. In that case, I would go for NSAIDs actually. If this BP would have been given, say 90 by 50. If it's given 90 by 50, then what? 90 by 50. Isn't it a sign of shock? If it's a sign of shock, uh, yeah, great. So if so, three type of question can be made, and we have seen in exam three different type of question. One, shock type of feature. Patient presents with shock type of feature. Patient is dehydrated. Patient presents with shock type of feature. You give the IV fluid first. Clear? Like channel open is a mandatory for every cases. Then comes um, this one. It's a sign of envenomation present. This bite was a red black spider bite. In that case, if envenomation present, we'll give antivenom. If envenomation not present, only given erythema or only given some other superficial thing, then what would be the answer? Then NSAID. So from one thing, it is possible like you can make it three questions. From one thing, you can actually make overall three questions. Okay, that's quite a possibility from this one. 2020, it was so anyone has exam, especially in the um, February, March, is a high chances like you might get this question. Those of exam in April, May, you might get more, some of new questions in February, March, and from them, like more new expected poisoning question might come. It is expected that February, March people might get also, a new poisoning type of question actually as well. If you're lucky enough, you might get a this question because it was tested last year this time. So high chances that you might get a new poisoning question again. All right, great. Before going to that one, sometime I like to ask question compare contrast. Can anyone mention what is the management for the jellyfish poisoning, which was a tested topic in 2024 actually. So 2024 highlighting topic was the jellyfish. So there is a something to apply on the skin. So in a one word, I want that answer. If you're answering the vinegar, if you're answering the vinegar, even that. So that one's answer was vinegar. So 2022 was this jellyfish one, and now this black widow, black, red, black spider thing was there. I hope that's clear. Can we move to the next one? And as you can see, the reference would be mentioned here. So this is the reference of this particular thing. All right. Next one, we can see a question of a 20-year man doing cocaine sniffing. Now, in our countries, cocaine may not be common, but if you go to country like Australia, UK, USA, what do you think? Cocaine, is it a common thing or cocaine is it a less common thing? What is your impression? Let me see with the so cocaine, is it common in this Western world? Coke, they call it Coke. Do you have Coke? I mean, it's like I have seen in a open road they are selling cocaine. You know, so it's so common actually. So if you are a druggie, other druggie will find you in that case. It is a very common one druggie and another druggie, they're like brothers actually. So it's their eyes will find you. The one of the they will be always in the side of the shop, sitting like that, and they're also keeping eye on if anyone is looking for anything there. So it's also common there actually, some of the areas actually. So I've seen it in Australia, UK. It's quite a common. I mean, some of the even city areas, central cities, they're openly selling like cocaine and many other things. So it's a quite a common. So cocaine sniffing, bulging under the neck muscle, and subcutaneous emphysema, this is a keyword. Okay, subcutaneous emphysema, crepitation during the auscultation, what is your diagnosis? Interesting question, a kind of new question of 2023. So you need to know this one before heading into 2024 exams. Okay. Now, what do you think about this one now? In this one, we can go into the answer, bronchoalveolar rupture, this one. All right. So this one was a bit new, bronchoalveolar rupture. We are thinking about this one answer actually. So what was the keyword? The keyword was bulging under the neck muscle actually and subcutaneous muscle. These are the some of the contexts which can be interrelated actually. So highly suggestive of bronchiolar rupture. Bronchiolar rupture. Clear everyone? Keyword. I mean, if I see this question again, bronchial rupture. Now, quickly differentiate with one another. Can it be pneumothorax? Can it be pneumothorax by any chance? The answer is if you see this question, I mean, um, less possibility. Why? First of all, I don't see anything traumatic. So many time the pneumothorax is a possibility. We expect that there could be some of the traumatic incidents. There's another version of pneumothorax that it could be that is spontaneous cases. But in those cases, some other predisposing condition can be present. Now, tell me one thing: in which cases a predisposing thing you are expecting? It is something related to respiratory system. Let's see. Yes, good one. Someone said pneumonia. Good one. Someone said pneumonia. Good one. I'm looking for another one. I'm giving you another chance to answer. Um, Close. If you say COPD, or also close. I mean, any pre-existing lung disease can lead to these things. Any pre-existing lung disease can lead to these things. But among them, there's another one. There's another. Let me give you a thing. Esophageal, another condition. Cancer also, like any predisposing respiratory condition. Someone said cancer as well. That can be. So one of the esophageal condition can also lead to this thing can happen. Especially there will be history of like conference meal before that or binge drinking. Okay, so answer is a Boerhaave actually. So if there is a Boerhaave, is that possible? There can be pneumothorax. So this is how correlation you need to do. This is how the correlation you need to do. So they can make that question and bring that question in that way. This one is not related with finding anything like that. So this is bronchiolar rupture. This is a bronchiolar rupture. And you can see this thing like a while tension pneumothorax can also cause of emphysema, crepitation, cochlear sniffing. But this is more consistent with the bronchiolar rupture. Okay, great. Moving forward, okay, about the reference, here is the reference point actually. Those of you already taken admission, the file is there with you. So you can check the reference, you can click the reference, it will take you to the specific website. Okay, moving to the next question. Now, head lice, it's a dermatological question. Head lice needs, I mean, guys, did you remember, like, I'm not sure how common it was in your country. When we used to be very small, now it is not. Our mom used to take us and, quickly they try to remove few lice you know different country it has a different name to remove those extra thing and they are sometimes running in the head. So I have only one time in my life, and there was another person who started living in the house, and from that person me and my sister got these things. Okay, now coming to the head lice needs treated with a permethrin lotion. Persisting needs, now what to do next actually. In that case, let's move forward. In that case, we are thinking about this thing as a using lice comb actually. There's a no point of no treating a pet dog is not an appropriate course of action here actually. When dealing with the head lice, head lice is specific to humans, do not infect the infested animals like dog. So you understand one thing, this particular thing like head lice in human are different in the animals actually. So many people this one is a distractor if you're thinking. So this one is a wrong answer if you're thinking. So use the lice comb actually. All right. Lotion. Okay, we already applied the lotion, my dear. Yeah, I think you have seen that in the question. So many time you have to see that questions actually. So already you have been given a particular treatment. Now you need to do ads on actually. So for lice comb is a quite a popular in the treatment protocol actually. Even if you see the RSCGP guideline, it's been mentioned actually. So we are following whatever it is given actually. All right. Wash hair every day with shampoo. Do you want to lose all your hairs actually? I hope so not. All right. Now let's come to this particular part. Uh, Persistent after the treatment of, so our condition is a primary condition or is it a step up condition? Let's check the question again. Our condition is a primary condition or it is a step up condition? What do you think? Let's comment. It's a step up. Already it is there and already few things have been tried. So it's a treatment which is failed somehow. So persistent even after treatment with permethrin lotion, which is a good thing. Now, essential to to eliminate them totally. So correct use of action would be using a head lice. Is a valuable tool. Now you are thinking it's not a valuable tool. It is a treatment tool as well. Valuable tool physically removing the lice and it's on the hair. It is often recommended to use a fine tooth comb to remove the remaining like lices actually. So your treatment will continue at the same time that lice comb should be added. Okay. Additionally, it is important to follow the instruction applying the permethrin lotion carefully. Also, everyone in the house should be also have been in close contact should be checked properly. Okay, so this is under the treatment, guys. So this is already, so this is step up treatment and it is a valuable tool using the lyscom, and also need to keep applying the permethrin. It's not like that you stop using the lotion and the cream, we'll keep using it. Let me add you like, for the head lice, we use permethrin. What is the percentage of this permethrin lotion? This can be a relevant question to our exam. This permethrin lotion, what is the percentage? This is a 1%. I guess so. Now, 5% permethrin is for which cases? 5% permethrin is it for scabies cases. So it's not the same actually. All right. So permethrin is a good one. Can be used for scabies, can be used for the head lices. Here's some more references. I think I take it from RLCGP and we are moving forward to the next one actually. Now here is something given. I'll show you the calculation at the end. So don't worry. We'll also have a additional biostat relevant class. So don't worry. We'll add that one in the routine. Okay. We'll take a specific biostat class for you as well. So don't worry about these questions. We'll also guide you more. Now, few things are given. Few things are given like that. What is the incidence of hypertension in a population? Any cases? Okay, moving forward. So we have picked up E actually. We have picked up E. Now, the reason why that one, you have the file. So please go through this calculation. I have written the whole calculation for you. Okay, so someone got it right. Here is the whole calculation actually. So number of new cases in 2019, population 2019 divided by that. All right, so that's the thing. Then finally, you have to also collect the incidences and all these things. All right. So this is how the thing sometimes with the bastard. Let me tell you one thing. Some of the doctors we talked actually, those passed in November, we have a tremendous result in November. Even if you see 142 passed, which is a very big number, right? I mean, from any context, any academy, whatever it is, in a month, if 142. So we also get to talk to them actually. So few they give feedback, few they so one thing they said, doctor used to say that biostat we don't really have to worry. So there'll be hardly one or two questions from the biostat. And for that one, you don't need to think too much. Even if you're not doing a one or two biostat, it is not going to affect your exam. But yes, if psychiatry, ethics, these things you're not taking proper preparation, it can affect you actually. So biostat will have a lecture, so don't worry on that one. We'll add that one for you. Right? So more things will come. That day there will be more calculation. But here I put that calculation, so do not worry for now. Now coming to the part, a patient taking sertraline and exercise experiencing like tachycardia, palpitation when combined with a benzodiazepine, what is the appropriate course of action? Okay, sorry about bringing the answer first. No, there is no negative marking. Perhaps, my dear, you need to see our my YouTube channel, MC Frequently Asked Question. If you can check, you'll get more clear idea about MC. Okay, great. So this one, we have picked up the answer as a C. Uh, the correct answer scenario, we picked up as answer as a C. Actually, reduce the dose of the benz dropping because tachycardia palpitation can be side effect of cholinergic medication like benztropine. So you need to adjust the dose of that one. Clear, everyone? So the benztropine is a drug that can be a side effect of cholinergic. We know that cholinergic medication can cause lead to palpitation. You need to adjust that one's dose. Clear, guys? This one's answer. Let me show that question again. Sorry, it was marked before. Yeah, so that is the thing. So it was very clearly given that benztropine, what type of drug? Cholinergic, that has the side effect of increasing palpitation. All right, so adjusting the dose. Read this question and try to answer this one. Okay, everyone. So elderly man with a hearing aid and bilateral curamine impaction, positive bilateral Renius and Weber test, Weber's letter is to the right ear. So what do you think what it could be in this case? Sometimes option also can also have issues. Like we can also make a right for the right answer. We can also make a E answer. So sometimes we need to figure out if recall may have issues or not actually. Let's say if I also add an option, sensory neural hearing loss in the left. Let me add something for that one, for you. So neural hearing loss in the left actually. Now let's think which one can be the correct answer. Yeah. Sorry guys, I didn't bring my drawing device. I just came to my country like, yesterday. So normally I have the like devices where I can draw in the screen. So I don't have it today, but from tomorrow I'll open my luggages. In next class, I'll bring that one, like, writing on the classes actually. So I'll do that one. All right. Now, for now on, like, we can use by the mouse sensory neural hearing loss in the left if we make an option like that. Now, what do you think? Which one can be the right answer in that case? Okay. Now, how many of you have problem in Rennie's and Weber's test? In that case, I can quickly brief this one a little bit. Yes. So correct actually, to be honest, like a uh, best actually answer should be sensory neural in the left actually. That should be the best answer in this case. All right. So yes, if you want, I can demonstrate a little bit from the John Murtagh ENT just to clarify this one. Let me clarify because one question, because ENT does not have so many questions. ENT has ear, nose, throat, but very specific, and sometimes they confuse with this particular thing, this Weber's test and the Rennes test. So for one time, maybe we can just have a look on that one, like to guide you guys a little bit on the ENT. Let me show you my screen. Yeah, it's okay. Let's do it one time. Okay. If you want to mark John Murtagh page, it's given in the 403 page actually. Okay, this is the chapter, that particular chapter regarding deafness, hearing. Yeah, deafness and hearing. So basically, if you count, there are like conductive deafness and the sensory neural deafness. So conductive deafness are these, especially see wax, anything external, and autosclerosis. So the marked one are more important because we have seen these things as a stem in the main exam. And sensory neural deafness, anything related to nerve like cochlear or whatever it is. So few we can guess automatically, like a acoustic neuroma, Meniere's. These are nerve related presbyacusis, we can understand. But also things like herpes zoster, you have to remember it little separately. And also traumatic. This trauma has to be in the inner ear trauma actually that can lead to this deafness. So that's why these are the sensory neural deafness. So basically this information is important, like which are sensory neural and which are conductive, because based on that one we use the Rennie's and the Weber's test actually. Okay, here is few lines are also included in John Murtagh 401 John Murtagh page, like this kind of lines, like a patient with conductive loss may hear better in the noisy environment. See, this type of information are very important, like paracosis. Conductive disease may hear better in the noisy environment. All right, because we raise our voices when the background is noisy, like a phone. Same as in some people are talking very loudly when someone is in a particularly crowded places. Okay. Conversely, or vice versa, patient with the sensory neural deafness usually have difficulty in hearing in the noisy. So this information is important. There are relevant handbook questions too in the ENT. They have made more questions. In general, the hearing loss causes are given here in John Murtagh. Now coming to the part for why we are here. is actually to see comparison between the Rennies and the Webers. Comparison between the Rennies and the Webers actually, which we are looking forward to do. Now, seeing this one like a conductive deafness and the normal and the Rennies test. Now, the basic is like how to do this. How to do this. Now, if you see this one, this is a Rennies test. We all must be knowing there's two types of tuning fork, right? Okay, anyways, you take any one, like a for using that one, you hit somewhere and you put near the ear. So this is the like some sounds will be generated. So this is called the air conduction. Whenever you are putting behind the ear, it is called the bony conduction, right? So air conduction. Normally, for you, me, for normal people, is this thing is related to air conduction is more than bony, or is it equal? Air conduction is more than bony for a normal person. What do you think? Let's see in the comment section. This is our first question. For a normal person like you, me, unless someone of us actually hear less. All right. So normally air conduction is more than bony. It's logical, right? It's like a air than in the bone. So air conduction more than bone. So coming to this is the important point that in a normal person, AC is greater than BC, but even in a disease, also AC is greater than BC, like a sensory neural deafness. Now that creates a lot of confusion. Like you do this tuning fork testing and you put there and patient says, no, I think I feel bony conduction is more. Now, if they said bony conduction is more than air conduction, in that case, what do you think the problem is? In that case, the problem would be if bony is greater than air conduction, it would be conductive deafness. Is it clear, everyone? In the basic Rennes test, if someone said, I think I feel like in my bones I hear more, that means it is a conductive type of deafness. Is up to this, is it clear to everyone? Okay. But if they said, no, I think air is more than BC, does it indicate that it's not a sensorineural deafness? If they said AC is greater, yeah, I think AC is greater than BC. I mean, I hear more in the air. Is it indicate always the person is normal? You understand the question? So AC is greater than BC can be two diagnoses. One, normal. One, it can be sensory neural. Now, is it clear, guys? When they're saying I'm hearing more in the ear, it means it can be normal or it can be sensory neural deafness. Either of the one. Now, question is how to differentiate. Now, the question is how to differentiate in that case. Now, the test came Weber's test. Clear now? Why we do the Weber's test? To differentiate between these two AC more than BC. Because normal and sensory neural, both we have, yeah, this thing. All right. Because there is a two diagnoses actually. Normal AC greater than BC, sensory neural AC greater than BC. How to differentiate? We'll do the Weber's test. We'll do the Weber's test. Okay, is everyone is clear about this thing? Is everyone is clear? Now we'll talk about the Weber's test actually. Now this is a very simple math. If you're not understanding, maybe math is very less. Maybe you need to practice math actually. Only one thing, like BC is greater than AC, conductive deafness, very clear. From the very beginning in the Rennes test, you understood there is a conductive deafness. But patient says this is air is more than bony, then it can be normal. It can be also sensory neural. Now how to differentiate? Now comes the Weber's test to play some role here. Now coming to the point, what do we find in Weber's test? Weber's test in sensory neural, louder in the better ear. Okay, louder in the better ear. Let's think the opposite. So hear less in the diseased ear. Can we just improvise that word? Louder in the better ear means what? It means, hearing less in the diseased ear. Can we say that? Hearing less in the diseased ear. You can just write it down here because they might give you the alternative word. So louder in the better ear means in other ear it is less in the diseased ear. Well done. Less in the diseased ear. Clear, everyone? So if they say no, I mean, when you are doing the conductive test, they're doing like that. They'll, hit the tuning fork and they will put in the middle of the head like that. And they're asking, which ear do you think you're hearing more actually? So if they said, okay, I think this ear I'm hearing less. Okay, so that might be, this is the diseased one actually. And this one can be sensory neural deafness. This one can be sensory neural deafness. If they said it, I think I'm hearing similar in the both side. What is your diagnosis? You do the Weber's test and they're saying, I think I can hear equal in the both side. Then I think what is your diagnosis? This is normal. So initially there was a confusion, AC greater than BC, AC greater than BC, both normal and sensorineural are same. But after doing the Weber test, they're saying, no, I think I'm hearing equal in my both there. It means this, it's a normal finding. But if they said, I think I'm hearing less in my right ear. I'm hearing less in my right ear. Right ear means diseased ear. Then what is your problem? So it's easy to diagnose. If they said, I'm hearing less in my right ear, my problem is in the right ear. Then vice versa, if I flip the word, I think I hear louder in the left ear. Where is your disease? I think I hear louder in my left ear. Where is your disease? So this is in the right. Then the disease in the right. Right? That's why I improvised that term. That's why I improvised that term actually. Right? So just like let's fix this sensory neural and the normal first probably. So they will tell like that. Let's talk about the opposite one, like a conductive. Conductive louder in the deaf ear. This is another one. If they said, louder in the deaf ear, louder in the deaf ear, and BC greater than AC, you need to have two finding. BC greater than AC, at the same time, louder in the deaf ear. This is conductive deafness. So it's all calculative math now. It's all calculative math now. So louder in the deaf ear. Okay, is it clear, everyone? So this opposite. Remember just one. To avoid confusion, just remember one. If you try to remember all of them separately, you will be confused. Just remember one. Let's summarize again. Let's summarize again. When you do Rennie's test, when you do the Rennie's test and put in the air, okay, AC is greater than BC. More hearing in the air than more in the bone. So this can be two diagnoses. Okay, normal and sensorineural. Now I put the like tuning fork again and put over the head. Now they're saying, okay, I'm hearing similar in my both ears. My diagnosis is, what do you think? My diagnosis is in this case normal. My diagnosis is normal. Okay, second scenario. Second scenario, put the tuning fork doing the Rennie's test, put here AC is greater than BC. AC is greater than BC. Again, hitting the tuning fork, put in the middle of the ear, Weber's test. Now they're saying, I think I'm hearing less on my right side. I think I'm hearing less on my right side. Now, what is your diagnosis? And diagnosis is a right-sided sensory neural deafness. Clear, everyone? Now, I also I tried enough. It was not clear. It was not clear. Even many times when I have gone through some good ENT teachers, but it was, I don't know, it was not clear. I don't know how, but it was not so difficult. It's more about calculative, because many time even they are a bigger expert, the ENT professors, they're trying to teach the both. And we get confused actually because what is going on? Rene is again Weber's, again two diseases are coming, conductive and sensory neural. We get confused very quickly. So remember one, the first one, it will be easy. Okay. I took some time. Sorry about that, guys. If someone is looking for more quick recalls, sorry, it's okay. But this one is often a gap. There's a thing. Once there is a gap, always there is a gap. Actually, you see, some many it's still while struggling actually. But try to discuss this one with a friend within next 2 days. Otherwise, you will forget whatever I said today. Okay. Try to give a demo to your friend very quickly in next 1 2 days. Otherwise, you'll forget that one. So coming back to this one, coming back like so Weber's lateralized to the right ear actually. So ceramine impaction level. So what do you think this one it can be? So this one is more like a sensory neural hearing loss in the left actually. We're expecting sensory neural. So sometimes they will use another synonyms like a lateralized to the right ear. So Weber's, which is lateralized to the right ear actually. Sometimes they will be using terms like that. So diagnosis is in the sensory neural in the left actually. The word lateralized means like a more louder actually. Lateral Weber's lateralized to the loud here actually. So Weber's lateralized to the, yeah. So that's the other thing. All right, great. Yeah, reference John Murtag. I didn't bring that reference. This reference was belonging to John Murtag. Great. All right, coming to this part, guys. Like for now, just remember that one. We'll solve some more ENT one. Okay, I'll bring in the next class two, three more ENT problem for you. Okay, it will be more clear to you then. Okay, I guarantee you it will be more clear. I'll bring that one for now. Just remember that finding. Actually, it will be great. Okay, great. Let's come to this one. For now, just remember that one. Okay, try to read this question. I'll start in one. All right. So, adolescent girl with hereditary suicide. I don't know why they're after this topic all the time. In our note, there is a separate note on the hereditary spherocyte. Okay, if you want, you can check that one. Okay, hereditary suicide is with a history of upper respiratory tract infection, which is not an uncommon whenever there is a hemolytic disease and this that their immunity is already low, so it is quite a possibility. Now, 4 days ago with a pallor splenomegaly anemia, so looks like it's a very classic case hereditary spherocytosis, abnormal shape of RBC. So these RBCs will be more restricted in the spleen. So eventually there will be pallor, there will be anemia. All right. So this is very common. Now, can we add this one? What type of anemia are you getting here? Very just to be sure that everyone understood that like more abnormal shape RBC which is distracted in the spleen. So what type of anemia is this actually? So this is more likely is a hemolytic anemia. RBC going and distracting more actually. It's a hemolytic anemia. Now, like my second quick question, if it's a hemolytic anemia, I mean, not related directly to this question, what type of hyperbilirubinemia are you expecting? Okay, direct, indirect, total. I mean, there's a three things sometimes given in the question stem: direct, indirect, total. So, what do you think? Which one can be raised actually in that case? Hemolytic. So that means in the blood it increases more. Hemolytic means blood it increases. So which one goes in the blood first actually more? So it's the indirect one. Direct one, my dear, it's related to biliary stool. So don't confuse that one. So in the blood, bilirubin is raised in the beginning. So it's the indirect one. So indirect would be raised. What do you think about the total then? Total will be raised. Okay. Indirect raised, total raised. If it's a biliary obstruction, then direct raised and total raised. Clear now, everyone? This is how a scenario can be given. So either they will give you a clinical scenario like this, either they will just tell you, okay, 7 years kid was brought and his lab is given like this. So either you diagnose from the lab, either you diagnose from the disease. Okay, great. Now coming to this one, this is very clear that this is the hemolytic anemia and hereditary spherocytosis is the condition. What do you think? What is the answer here? Folic, blood cell transfusion, splenectomy. Okay, let's see. Answer can be. Mhm. Okay, maybe second bamboo of the day, but I'm coming to those points actually. A folic acid, then B, then C. Okay, you don't believe me, right? I guess. Okay, no one believes me. Okay, all right. These are the basic things. The reticulocyte number increases, jaundice increases, indirect bilirubin. We know about these things. Coming to the lab part, don't worry, very soon. Can be mild, moderate, severe. You can check this file actually. So mild, moderate, severe form. And let's get into more thing. And now you see the treatment. Now you see the treatment. The folic acid supplementation, my dear. Okay, so this is the thing, my dear doctors. So moderate severe 1 to even milligram wise it's given, pregnancy is given. Then comes the transition, then the thing. So now is it clear to dear doctors? Like even folic acid is can be used as a general management, right? Even in these particular cases. Even in this particular cases, there's a general management. There's a more things. Let me show you in a little bit more. Okay. I hope so you can see in the screen. Let me turn off myself so that you all can look the full screen. Okay. Now you can see this is a very common hereditary hemolytic disorder. We all know. So this is a more important information. We know it already. Some parts like European countries is more common. Like in Australia, we can also see that. Common features, of course, there will be jaundice and anemia. And what type of anemia? Hemolytic anemia. All right, so these are more common actually. So splenomegaly, these things are more common. Some cases can be association with the parvovirus. Please note this one. Like hereditary spherocytosis, this thing, some cases can be related to parvovirus. Please take note on that one. Some times they will mix up this one. Investigation wise, like blood film, this, that, they will do reticulocyte count increases. No reason, because the reason is more RBC is produced. More RBC produced, so more reticulocyte actually. But it doesn't mean that more reticulocyte means more RBC, because they are eventually distracted. So bilirubin increase because more RBC is breaking down actually. So a few more things are given. And last but not the least, we come to the treatment like hematinics. This folic acid thing, if you, I'm not sure you remember from our hematologist learned the word they used to call hematinics. Okay, so maybe you remember as the term hematinics. So hematinics is used in this hemolytic anemias initially. Then comes the transfusion, then comes the other thing. So this hematinics is a folic acid. Now let me show you the question again just to be sure that you understood everything. So is it clear to my dear doctors? Like hereditary in earlier cases, we start with a folic acid, then come the transfusion. If it is too much mechanical, big spleen, then we consider the splenomegaly later. Everyone please answer as a yes if you understood. So A, B, C, both are treatment, but folic acid to give first. Right? Moving forward. Let me tell you this folic acid related treatment thing, it's coming from many time actually. Yes, this PPT will be given later, definitely. I mean, already those joined the PPT already, they got it actually. You can check it in our folder of 2023 April folder. It's already given. Those have joined already. If those not joined, or maybe yesterday those taken admission, I didn't send the file yet. I'll send the file. Clear, everyone? Wonderful. Wonderful. Next one. The same case possible cause of presentation is what? Oh, I think I already told somewhere. Same case, what can be the possible cause of presentation? Parvovirus. Now, I think previously I told that one, or maybe some of you guys are talented, I know, or this one. So here is that reference again, severe anemia with concurrent parvovirus infection. So this condition can be related to that actually. So two questions came from the hereditary spherocytosis system in 2023. About hereditary spherocytosis, it is a tested topic even since 2017. It keep coming in a different form. Sometimes they ask to make a diagnosis. This time they ask the cause in that way. Also, they ask another question even that's a treatment. So it's a like a 5-star topic. Great. Uh, Reference the previous slide. Yeah. Baby with jaundice on the third day. So jaundice in a different day is makes sense. So first day is a pathological, second, third day is a physiological. I hope most of you know it. Born with a vacuum associated delivery, presents with a cephalohematoma. What is the treatment? So they're looking for like a something like a cephalohematoma. So what do you think? What we should answer? Keep going, guys. Keep going. I'm giving you 10 seconds. All right. Best answer would have been, observe and follow up. I think agreed with some people. Since that option we didn't get, well done. If someone said observe, follow up, and level of bilirubin and this thing is also required. This is how the recall are sometimes. So there's no profession like blood transfusion or like exchange transfusion to do something too early and the things like that. So probably it's a physiotherapy, the basic actually. But otherwise, if follow up and these things are given and bilirubin level are given, so we can think about that option as well actually. All right. So correct treatment, the baby with a jaundice resulting called cephalohematoma, highlighting what is it this due to vacuum-assisted delivery generally is a phototherapy. So this is the extract we got from the internet actually. That so standard treatment for neonatal jaundice. So phototherapy is a standard treatment for the neonatal jaundice, as you can see. All right. So in cephalohematoma, this also hyperbilirubinemia can happen actually. All right. Now coming to the second part, like if someone thinks about blood transfusion, is reserved for severe cases of jaundice. So if it is too high, maybe over the 20, the level, then you can consider that actually. Clear everyone, this question? I hope it is. Okay, next one. A patient brought to the hospital by his girlfriend, which while investigation, he says, I love you, I love you. Okay. Okay. So what is the diagnosis? Maybe watched the Devdas movie many times. Anyways, anything can happen. Patient brought to the hospital by his girlfriend. What could be the reason actually? The girlfriend is fed up. Okay. Whatever it is, what is the diagnosis? Okay. So think about the mania. The patient is not of her own actually. So let me highlight this part. The patient is not of her own and not a histrionic personality either. Histrionic personality like a selective personality, that's a different. So the case of mania, it seems a bit crazy. So that's the thing. Why not hypomania actually? Yeah. Girlfriend would never bring for saying, okay, it's a good one. Someone, is a really good one. Someone added, girlfriend will never bring for saying, yes, that's probably is true actually. Anyways, why not hypomania? No goal directed activities and also not that kind of talking. Okay, so it's not covering or matching with hypomania. They are more goal directed. This is not looking at goal directed, so that's out. Histrionic personality, seductive personality is not like that. That's out. Paranoid, not really. Not someone is suspicion, like nothing like that. So that's also out from from the option. So we use the exclusion method. It looks more like a mania actually. Okay, it's like he's getting crazy actually. The person is getting crazy. All right. Next one. It's a direct answer. I remember it tested in somewhere in 1 2 year back, and now it came again actually. So risk percentage of radiation in CT scan. You might see this one as a new question, but I have seen this question coming previously as well. All right. So that is the thing. Now, what do you think? So this is a straightforward answer. If you know, you know. If you don't know, you don't know. This one. This is not a calculation. So going for the answer, 5 more seconds. All right. Now, going for the answer, here is the answer. It's a 20%. So radiation doses are common. CT scan is like a something 25 that is mentioned. So it's like a 20% is more actually. So it goes with the 20% more actually. A actually. So it's a little bit difficult, but we checked it, cross-checked it with the references. We figured out it's like a 25. So it's like a 20 is the nearby one. So 20%. So coming back to this one again, 20. We figured out 20 is a more close one. Okay, that's why I said this one. If you know, you know. If you don't know, you don't know. It it can be a difficult question in the exam in any way. Talking about the MC, I mean, let's see how much idea you have. Actually, do you know? Is there any pilot question nowadays? This is a lecture I'm taking in 2024. It's 2nd January today. Do you think is there any pilot question remaining? If you see our previous AMC videos, we used to talk. There are like 30 questions or pilot questions and this that. So do you think pilot question exist nowadays? The answer is a no pilot question. So there is like a no uh, pilot questions nowadays. No pilot questions. So please keep this thing in mind. Like yes. So let me talk about a little bit, format of the exam in 5 minutes. Maybe it can be useful. So 150 questions, and there is like a 3.5 hours You can calculate. No pilot, no negative markings. Okay. Any flags, like previously, I mean, we used to flag the question. Okay, we'll see that one and check this one after the exam, after the exam finishes. So can we do that anymore actually? So no flag options anymore. So no flagging. Flagging is also gone. Okay, so this is what it is actually. So no pilot question means no trial question, which was previously included. Okay. Another thing, if someone failed with 249, rarely, not rarely, I've seen people failing like that close mark actually. Any benefit of reviewing? Even not many are my students also, sometimes we got a lot of messages. So any benefit of reviewing about that one? Because individual question can be 3 mark, 4 mark, 5 marks like that, because 150 question and total marking is 500. So 150 question, but total marks are 500. Total marks are 500. So for passing, you have to get 250 out of 500. So you can understand not every question is 1 mark. Individual questions are having different mark. Are different mark actually. Now, what is the benefit of doing recall, or what is the side effect of doing some recalls actually? Okay. So benefit of doing recall. You are doing the recall. So benefit of recalls uh, can be a lot common in exam. Also, we also do a lot of recalls on exam days actually. As if you remember or see the routine, if you see our routine, like say February exam group will give support, for March group will give support. Also, those have exam in April, May, June. We keep having our support group. So don't worry that you will not be left over even if your course is finished. You will be added actually. Okay. No, it's not good to review actually. That's what I was saying actually. So benefit of doing recalls actually can be a lot common. Like last November, there's some doctors said they even get like a 60% common. Trust me, this happened actually. So exam days we give support, and previously so many, these things we solve. There's so many, but what's the result came? 60% recall actually. So how much marks you are expecting? Yeah, 90% also someone mentioned actually. But what's the result was there? Did you heard someone getting 400 out of 500? Did you heard this thing? If someone is telling, oh, doctor, I got almost everything common. Now what happened here? No, we know. I mean, someone got 300, I know already, so that's the thing. Um, how about why the marks is not coming like a 400 then? Let's guess it. So some hint is here, like, about the marking system in them. In MC exam, though, this is the benefit of the recall, like, that can a lot common in the exam. A lot thing common in the, so it's a disadvantage. Disadvantage. I mean, if you're only dependent on the recall, then the problem will happen that you are only expecting the one to come common. You are not using your conceptual things actually. Right. Now, not answering conceptual question will lead to um, getting less marks. You understood now? This is the thing. Like you are answering the only one, those are the common one. And AMC marking is kind of like this. AMC markings are related to, the number of people answering that question versus the number of people correcting it. So more people correcting it. Do you think answering that question you will get more marks or you'll get less mark? You see, maybe a question I'm solving here, and everyone started answering it. That question will give you more mark or less. You might get only 1 or 2 for that one. Rather the one that they bring new and you can't answer from your conception. That question may have almost 5 marks, possible, or 6 marks maybe. You understand the thing? So this is like the probability. This is the thing. So that's why marks goes down when you. That's why theory is also important. Many of our students, at least they get nearly 300 or at least good marks actually, because they have good theory knowledges actually. So if anyone in this batch for the first time, if you started doing MC and never have done theory, you could be in trouble actually. You understand what I mean? So, so conceptual theory is also important so that you can answer those conceptual question which carries more mark. So that's why few days back I posted 2024 can be more tricky because they might bring more conceptual questions actually. All right. So in that case, that's the thing. Exact marking, it's difficult actually. Exact marking, like see, example, if I set up a mock test, you will get mark like say 300. Let's say out of 150, you pass like a 75 question you correct, and that. So that kind of mock test is not existing like in anywhere outside. You understand what I mean? Because they are calculating the number of people you know doing that one right. We can make a mock like a computerized, or anyone can make a mock computerized. It will never be like the original one. You understand why I mean? Because they also calculate like a with a supercomputer, like how many people answering that one correct and how many people make it wrong on the basis of that one. It's like a those of you follow cricket, it's like a Duckworth-Lewis method. You remember there was a when there is a rain comes, some weird rain system they follow actually. So it's kind of like that actually. So that's the thing. They want more people fail, yes. That's the plan, but don't worry, we will manage something to pass that one. Like nowadays AI came, but AMC is doing that one since very long, that they are doing it, how many people attending and this that. Now let me tell you a story. In 2000, I think 21 end, in November, one doctor texted me, doctor, my result is withheld. Okay, result withheld. Why? Result withheld, they said this message me something like a rote learning. Rote learning. Now, do you understand what is rote learning is actually? All right, rote learning actually. Now, that person is confident. And not only that, because November we have so many candidates. This time, 142 pass. Previously, not this much, but it was also good amount. So three of them result was withheld. And three of them texted me, doctor, it's also new for me. I also fall from the sky that what happened here. Now rote learning means I search few things in internet, I find out rote learning means the word, the rafta, or just like a you just memorized it everything. Okay. Answer pulmonary embolism, answer like this. Now when you answer, computer can detect how fast you are answering this question. You understand what I mean? That normally when there is a question, what people will do, people will read that question, then they will think, then see the stem, then I will answer. Now the rote learning people, because they memorize them before going to the exam, oh, that question C, so in a millisecond they're answering that one as a C. Oh, it was solved by Dr. Shahriar in the yesterday, okay, it is D. Now the thing is, after that one, the thing, because previously there used to be more recall come in the exam. Okay, so there's so many that okay, C. Oh, that question D. Oh, this is the option. Now, computer can detect how fast you are answering question. A human can't answer question that fast actually. So they're familiar with everything that people solve, recall, or this, that. So result with them. Tell them that I I ask them to write a common thing. So tell them I was so confident with my exam that I see that question I understood. They send that one, then they clear it actually, the exam actually. Maybe next time if it happened with anyone, please do ask me, so that every time the same answer, it might be again another rote answer. Oh, everyone got stuck and they sent the same words actually. Okay, our preparation was so good that we pass it actually. So thing might happen. I'm not sure you see that Donkey movie or not. There was a something with the IELTS preparation, right? Someone was using like a common formula. So make sure, make sure you don't use the common answers. Yeah, this one I'm just telling the template that, that my preparation was so good that, I questions were so easy for me actually, this, that actually, and they believe it actually. So make sure you don't use this answer next time actually. All right. Great, guys. Sorry about the times, but it's okay to be familiar with the other things of the exam actually. Now, coming to this one, 10 years old girl complains about dysphagia, feeling good, and food gets stuck in the throat. Guys, I'll answer a few things at the end, so don't worry. Have complained about the past 7 months, no abnormal finding, and mild eczema. Please check this question again. With just 10 years with the problem with dysphagia. So it's a ENT and the GIT related question. Seeing the question, thinking that which system question this is, this gives your brain more time to think that, which system question is that. Getting stuck in the throat every time she eats, like so, something difficulty in swallowing as well. So complaint for last 7 months. Okay, so for a particular time. And also said something with the allergy. Like another day we say allergy are like bhai. Allergies are like brothers. If one allergy present, another allergy can be present, right? It's very common actually. I know, some of my next door neighbor, like, the mother has, you know, asthma, the kid has skin problem, other has allergic rhinitis. So it's so common in the family. Like it's called atopy, family pedigree is quite a common. Now, coming to this one's answer, do you think it's a psychological, like a, globus? Is this a globus, or is this a achalasia, or is this a eosinophilic? All of them can be correct. Now, answer in here, we'll go for eosinophilic because the allergy is there actually. There's another allergic thing is there. All right. So eosinophilic esophagitis. Now, if I want to bring a more uh, specific line, there was another more specific line. Okay. I mean, previously, like a 3 4 year back, there was another question regarding that. My job is not to tell this question, what came in past to tell you also, or familiar, make you familiar with that. There was another question. It was given a endoscopic finding. Okay, allergy was also given there with some particular food they have problem. That question was there was some problem with some particular food, and also at the same time there is a endoscopy showing multiple constrictions actually. Endoscopy showing multiple constriction on the endoscopic biopsy finding. Now the answer is a eosinophilic esophagitis. Don't forget to see multiple barium pictures. Don't forget to see multiple barium pictures. Actually, let me show you. Do you want me to show some barium pictures, guys? Do you want me to show some barium related pictures? Like out of those questions, nothing will come in the exam. I can guarantee you. Okay. Now let's see some barium questions, like so that you be sure that there is nothing coming outside. All right. Any cases of this? This is a tough one, I would say. So this is a tough one. So don't worry about that one, even though this is a tough one actually. Not look like achalasia, not look like, yeah. So this is more look like hiatus hernia. My dear doctors, this is more looks like hiatus hernia. Okay. This will come as not only as a picture, they'll give you scenario. The person is obese, the person has a ZERD type of feature. So remember one information, a correlation. Hiatus hernia and the ZERD are very interrelated. Did you know this info? Hiatus hernia and the ZERD are very interrelated. So they'll give you a feature of a obese or a ZERD, and the picture they'll give you this thing actually. So you can guess it actually, that one. Now, what is this? Like, let's focus on this part, not this part. Let's focus on this part. It's become narrow. It's become like a tail, like a bird beak, okay, rat tail. So this one is a echalacia. Now this is a more classic actually, like a dead rat and its tail. Okay, again the third one is a also echalacia. Well done. The fourth one, let's see. This looks more complicated. It looks like someone has a take a bite from here. It looks to me like someone has taken a bite from here, which is called a filling effect, or a apple core you say, or filling effect actually. So this one is related to cancer actually. Cancer, filling effect. All right. There's another one. This is uncommon. That's why I mentioned this one. Is a pharyngeal wave. This one, pharyngeal wave. This is difficult unless you know it. Yeah, pharyngeal wave. Yeah, cancer esophagus was previous one, which was a filling effect actually, and this one is a pharyngeal wave. So this is kind of, it's like a wave actually. It's like a wave, not necessary. Yeah. So again, you see some filling effect. Some filling effect if it is there. In case of carcinoma, again, someone has taken a bite like that, filling effect. Bird beak appearance or rat tail is the same. That is related to achalasia, my dear. Yeah, it's like suddenly achalasia. Sorry, hiatus hernia again. Now, tell me this one. This one is most popular, also tested last year. What do you think? This is like a, for opening something, like a maybe a, what to say, Coca-Cola or wine or whatever it is, I think. It's like a corkscrew to open those things. So corkscrew appearance, this is for the esophageal. So extreme hot or extreme cold will lead to, extreme hot or extreme cold will lead to this spasm thing happens. And the diagnosis would be esophageal spasm. You need to give calcium channel blocker, correct? That's the thing. Okay, are you clear with this? Some of the esophageal things now. Eosinophilic esophagitis, we haven't seen in that way um, coming separately, but it was mentioned multiple constrictions. Okay, so that's why eosinophilic esophagitis, we didn't bring anything because there is no such barium finding. There is no such barium finding for eosinophilic esophagitis. A quick information to all the dear doctors to see more radiology. Uh, a good website. I use two things of often. One is a Radiopedia. Okay, its name is Radiopedia. Radiopedia is a official website to see lot of radiologists in a HD. You like to see HD, like when you see a movie like a hall print version, and when you see a Netflix movie, there's a lot of differences, right? Sound quality, this that. So same thing is like that. When you see something in the Radiopedia, you see the HD quality. All right, or otherwise you can Google it actually. Like a go to Google image and can type. You can see 5 to 10 pictures. So this is a common practice I recommend to all the those people are taking classes, that anything, because I show you one picture, the next picture you get, it might look a little different. So try to see more pictures from the Google image actually. So you can just type uh, Google image like example, and Google image will open in the Google, and you can just type eosinophilic esophagitis. Okay, that's the other thing. Or you type eosinophilic esophagitis in Google, and Google has a waveform and the image form. You just click the image, actually, more images will come. Right? Moving forward. Here is a John Murtak reference. In John Murtak reference, these things are mentioned that initially there can be has a relation with a certain type of food or certain type of allergy associated with allergic disorders. In our question, it was mentioned eczema. In our question, it was mentioned eczema. Okay, that's the thing. Yeah, I mean, we have a radiology album. We'll give you introduction to you. Don't worry on that one. What are the important diseases to see? We have already collected radiology actually. Yeah, yeah, no worries. We'll give you. Not a problem. Okay, if they ask you that, what is the management? Okay, good question. Eosinophilic esophagitis. What is the initial management? What do you think, guys? What can be the initial management in eosinophilic esophagitis? Is it a PPI or is it a corticosteroid? So answer in the most cases depends on severity. Most cases it's a PPI we started with. Okay, and additionally we add on later steroid actually, like fluticasone and this thing. We think we add on actually. Clear? All right. And you can see IgE can be elevated, allergic conditions like that. Yeah, fluticasone is mentioned here, like a steroid. And I add that line, it is not mentioned in John, barium solo is initial study. Barium is some of the initial study. Later you might need a endoscopy to see there's multiple constrictions can be there. There can be multiple constrictions can be there. Moving forward to next one. Next. Bright red bleeding after vaginal delivery, blood loss of 1500 ml, complete removal of placenta, no sign of infection in uterus palpable below the uterus. So what to do next? Here's a full stop. Uterus is palpable below the umbilicus. What's next? One option. Another. What do you think? Okay, let's reveal the answer. Hmm. Guys, is there anything mentioned? Like, see, many of you are answering, let's see, with the A and this, that. Isn't this one is a very common mistake? Yeah. Like, here is a tip for all of you today. The tip is, uh, sorry, I didn't bring my some of the drawing devices actually because I just landed yesterday night to Bangladesh, and everything is like in the suitcase actually. Normally, I use a lot of drawing and writing. Sorry about that today, but from next class, definitely I'll bring that one. Thing is here, in questions like this, they will tell you something which is like a um, after initial resuscitation, what to do next. Is this thing is mentioned in this question? What to do next? Is it mentioned or after initial resuscitation? This is a tip. And another tip for today is checking the question in after resuscitation, what to do next. It is written or it is written just what to do next. Okay, so this is important. So even in a serious condition like this, you need to start the fluid. Actually, definitely will go for blood transfusion. That is most appropriate and all these things. But with that kind of situation, even the paramedics can start IV fluid, isn't it? So if IV fluid is not mentioned in the question and what to do next, of course, you have to open a channel and start giving the fluid immediately. By the time blood cross matching this, that it came and then you will give it, right? It will at least take 10-15 minutes for the blood to give. Your patient can get into the shock by this time. So you need to give IV fluid even in between that time. Okay, sorry. This question is earlier, I think answer is given. Elderly man with a rectal bleeding, and so somehow if you don't get the source of the bleeding and could not be found after endoscopy and colonoscopy. Every year I saw this question. I don't know. Maybe that MC examiner has some problem in his rectal area, I think. So I think every time he's also having capsule endoscopy all the time. And these people already have, lot of hookworm infestation. I keep telling every year, especially in the December, January, you will see that they always try to, increase some new questions in the beginning. So after eating, this December and drinking in the December, January, all the hookworms started dancing, in their tummy. And after that, after this itching, they start bringing more new question actually, Anyways, that's a hypothesis. I hope so. They are not hearing. It doesn't matter if they hear actually. So anyway, so here is the thing, So obviously, and this question, all the this question, that's why they're favorite actually. It's because they always have to do capsule endoscopy and this area. Someone send a nice picture of, yes, they have like a more larger one like that than that. So capsule endoscopy is the answer. When you are not sure with the endoscopy or the GIT, I'm not joking now. Like when you are not sure where the bleeding is coming from and upper GI endoscopy, lower GI endoscopy, the bleeding is coming from somewhere, then capsule endoscopy. And these people have hookworm for sure, actually. So they definitely need endoscopy all the time, and capsule endoscopy is required for them. Yes, this is a picture of capsule endoscopy. Remember, guys, capsule endoscopy, you have to return that capsule. Very expensive. The one incident happened that, okay, capsule endoscopy given, capsule endoscopy is taken, the patient went home actually. All right. So the pictures came, the capsule was gone actually with the patient, and patient went to their own toilet and then done and flushed, and the patient was fined later actually. So please tell your patient that this is an expensive device we are giving. You need to return us back this thing actually. Okay. So, anyways, all right. Some indication. Make sure if you have a narrow bowel, you don't need to. Uh, give any capsule endoscopy because it can be because some rare cases capsule can return. So this slide has been taken from Davidson Medicine. All right, my dear doctors. Next one, elderly man with pain with the right upper quadrant. Yes, pain with the right upper quadrant. Upper ultrasound reveals inflammation of the gallbladder with stone obstructing the bile duct. Type of fluids. Antibiotic is given, but symptom does not resolve. What to do next? So pain related question will be there. Pain here, pain there. abdominal pain, upper quadrant pain, lower abdominal pain, appendicitis pain, gynae ops related, so many types of pain will be given. Pain related question everywhere. Okay, our life is full of pain, and AMC itself is a pain, right? Okay, all right. So, what to do next in this case? I mean, not about like the other pains of your life, but this question pain actually. So, finding here ultrasound is revealing inflammation of the gallbladder, obstructing the bile duct. IV fluids and antibiotic is given. So, this is important information, but symptom still doesn't resolve. So, it's like a step up in the management actually. It's like a step up in the management, right? Because investigation and initial things are given. It doesn't resolve. So, what we're going for is a laparoscopic cholecystectomy. So, this is something you can go for. So, ultrasound showing inflammation of the gallbladder. If you don't have a particular complication, if you don't have a particular complication, does they mention anything about a particular complication, or patient is hemodynamically unstable, like patient is getting into shock, or patient has a very complicated one? Is anything mentioned like that? It's a simple case of like a infection, inflammation is happening. So in that case, I think antibiotic has also been given. It's not been tried. So definitely you need a laparoscopic one. Isn't it like a day-to-day scenario what we see? What do you think, guys? Isn't it like a day-to-day scenario what we see? All right. No, it's still even laparoscopic one when you do there can be stone, doesn't matter, right? Percutaneous cholecystectomy, I mean that's required when there is a complicated case. All I know that percutaneous cholecystectomy we consider, later I can submit that one. What are the indication of percutaneous cholecystectomy? There's a list of things actually. It does not cover that one. So this is I don't see it's as a complicated case. Okay. If it's a typical stone, obstructing the biliary area, I can understand that, in that case, ERCP can be an indication. ERCP can be an indication actually, right? Mm. Okay, I'll look into this question. Okay, I mean maybe we may have some confusion in between option B and option C. Maybe I can review this question and bring that answer tomorrow. How about that? Try to look into this question. Don't worry about that. Uh, they mentioned, I think, inflammation of the gallbladder. I personally feel they mean to say that a stone is there actually. I think I personally believe they mean to say what I was also trying to mean is actually there was a stone there actually in that gallbladder actually, because if it's a biliary stone related question, they would have bring ERCP and this kind of options there, isn't it? So nothing looks like they have mentioned anything like that. So it's more look to me like a ultrasound showing inflammation in the gallbladder. Also there's a stone in the gallbladder. I feel so question can be like that, what I'm guessing from these questions. And the answer is really a laparoscopic cholecystectomy. In order to be answered laparoscopic cholecystectomy, we expect the stone is in the gallbladder. Clear, everyone? I mean, I'm also agreed with your concept. The stone should be in the gallbladder. Stone should be in the gallbladder. But if it's like a biliary area, something, the actual complicated one, then of course we need a more complicated like ERCP procedure and percutaneous than in that case actually. Right? Good. All right, we'll answer that one. Someone remind me later. Maybe class monitor can send me a text later. I will bring that question separately. Okay. I mean, I'll clarify this one next. That's how we get better and better the next day. So in the next day class, we'll start with this question then actually. Like I'll also tell you some pros and cons and what different type of question has come. Since some confusion arises, usually I try to clarify those things actually. All right. Like middle-aged man with no history of colon cancer and no sign of disease seeking colon cancer screening. Middle age, so not over 50, below 50. So recommended screening is option for individual according to general guideline. So for colon cancer, you can always check colon cancer and RSCGP guideline. You will find so many options actually. So what to do in this case? That's the thing. So in this case, I think it would be ideal. Um, it would be ideal to do occult blood test actually. Okay. Now, regular colonoscopy from every 5 years. See, there's the option IFOBT or FOBT. There's the option uh, would be best if given 2 yearly, to be honest. If it would have been given 2 yearly, I mean, I think this is a one-time just testing because patient is requesting. Perform an annual, like a one time you can do, that will be fine actually. But a typical IFOBT, it is written as I immune FOBT. It is mentioned 2 yearly in the colon cancer list. So in that case, I think one time you can just do fecal occult blood. Colonoscopy is a more complicated procedure. So sometimes when patient wishes, you can do this kind of like compare contrast. Prostate cancer screening. If patient wishes, can we perform the prostate cancer test? If patient wishes, like normally it is okay after 50 you can, but patient in 40, no, I have concern and this that, can we perform like so? Yes, in that case, initially we try to make them understand and tell about the pros and cons. But if we don't get agreed, then in that case, we do perform the PSA. All right. So the screening thing is sometimes on the patient's wishes. If they tell you first, like, in that case, it will be okay. So ideal as like you guys mentioned, FOBT is normally 2 yearly. More details you will find RECGP, colon cancer. If you just type, you'll find all the colorectal cancer related details. Here's some little bit more details. Let me highlight this part. So asymptomatic people, like, from age group like this, asymptomatic people, moderate risk, like first degree relative, diagnosed before 55. Yeah. So there's more early we can start, particularly these things. Yeah. So these are the options and these things are given. Mind date, there can be so many things. So blue book, I think, mean to say, I think handbook. I think there are relevant lot of questions are present. Relevant questions you will find there. All right, no worries. Okay, moving forward. Moving forward. Blue book means it is mentioned handbook, NC handbook. Okay. Not all cancer screenings are too early. Different cancers are different, actually, not like that. Okay. Like even diabetic retinopathy screening, it can be 1 yearly by some optometrist and 2 yearly by ophthalmologist. Okay, let's focus on this one. Incidental mass found by the mother in 2-year-old baby on the left sided flank. What do you think? Incidental mass found by the mother in 2-year-old child on the left sided flank. Now, certainly some few things are missing. That is, the baby is toxic or not, or is it crossing the midline or not? Nothing mentioned about crossing the midline actually. Now, in this one, we think it's a Wilms tumor because if it's a neuroblastoma, patient would have been more toxic. Patient, there could be things like that. Midline crossing, midline crossing. I'll show you the difference chart here. This is the differentiation chart. Nephroblastoma means Wilms tumor. Neuroblastoma means this. Now you can see some points like more toxic, does not allow you to touch. Talking about the neuroblastoma, irregular and hard finding. Okay, and it crosses the midline. Nothing mentioned like that. So it does not cross midline. I mean, we're just assuming from the question, or patient is less toxic, nothing like that. Hematuria is a plus minus in Wilms, so as like in our question may not be present. So it goes more with the Wilms tumor. What do you think? So incidental mass, the left side of the flank. I mean, it's a two shortcut the Ricola has mentioned, but we just assume like patient not toxic, no midline shift. So I think it can be Wilms tumor. But toxic, midline shifting, this thing mentioned, then it can be neuroblastoma. Okay. Middle-aged man with anorexia and weight loss and mass on the supraclavicular region, what to do next in that case? So let's say middle age means like a 40, 45. And there's a mass on the supraclavicular lip. So I think it's an easy one. I mean, unless you don't confuse too much, it's an easy one. FNSC. No, I don't know. If there's a mass in the supraclavicular middle age, so definitely you should rule it out by FNSC actually. Now, why is that? Now, the scenario might demand middle-aged man anorexia, weight loss. It is indicating, first of all, as a what? Maybe one option like a abdominal pain supposed to be present, but some cases may not be present. Can we say like a middle-aged man, this can be related to stomach cancer or something like that? What do you think? Is it a possibility? Middle age, anorexia, weight loss, stomach cancer. Can it be a possibility? Yes, it's a possibility. Because why weight loss came all of a sudden in anorexia? Anorexia is a feature related to your GIT. When GIT, anorexia is a GIT feature, and at the same time, weight loss is a in general cancer feature. Okay, so it can be indicating a maybe an stomach cancer. Maybe there can be a family history too. And mass on the supraclavicular node, isn't it a more clear view? Parcos triad. So if it's a varicose triad, it's related to stomach cancer. So you need to definitely do an FNSC. Yeah. So middle-aged man presents with anorexia, anorexia weight loss, mass season, it comes concern of various health issues, including malignancies. So you need to do an FNSC. FNSC. Next one, 2-year-old child with a painless lateral neck mass with neck extension. With the tilting the head on one side, what is the diagnosis? Now, tilting, okay, the one side, what is the diagnosis? Okay, many people are with the B, many people are with the C. The final answer is here, going with the answer C. Sternocleidomastoid tumor, actually, it's a specific one. If cystic hygroma, they'll tell you about ultrasound finding or a MRI finding, it's more like that actually. Right, so that what tilting like, so if you see, here is the details, sternocleidomastoid tumor, mass in that particular sternocleidomastoid area. Sternocleidomastoid is a long paired muscle located each side of the thing. It's not considered painless lump. And tilting the head on the one side, this is another key feature. Tilting the head on the one side is a key feature of this one. So this particular condition is related to sternocleidomastoid tumor. Tilting the head in the one side, it's a common feature of them. Clear everyone? Specific conditions sometimes can demand specific thing. Specific condition might be related to specific findings actually. Okay. It's already given here in the treatment. You can just have a look. How about the prognosis? You should know about the prognosis of some of the tumors. So stenocarditis tumor are usually benign, and with appropriate treatment, it will be fine. Sometimes it is required about the tumor prognosis. Some of you might be thinking about the cystic hygroma. Cystic hygroma, they might give you a picture like that. Long back it was tested, and later either ultrasound or MRI type of picture can be given actually for a cystic hygroma. All right. So whenever you read surgery, it's ideal if you can read about the midline tumors, lateral neck tumors. So if you divide the neck into midline and there are triangle, anterior triangle and posterior triangle. So the triangle based, if you can read, take a note. If you just Google it, what are the structure related to anterior triangle? What are the related to structure related to posterior triangle? I mean, we read that one in ENT and also in anatomy, right? In MBBS. I mean, you can just recapitulate that one time. That just Google it one time just to memorize that one again. Like what are the structures related to anterior triangle? What are the structures related to posterior triangle? And what are the structures of the midline? Okay. So just check it one time at your convenience actually. All right. Summary small I made already. Congenital condition, cystic hygroma, cyst-like fluid-filled sac, swelling and difficulty in swallowing. And you might need a ultrasound at the same time. Small doing this kind of summary is always good, right? I mean, so congenital condition, fluid filled, cyst like, Okay, difficulty in breathing, some cases, some people, and ultrasound finding. Now, this one is a cystic hygroma. Head tilting is related to, don't confuse, my dear. Head tilting is related to the previous one. Sternocleidomastoid tumor. Don't confuse, my dear. Okay. Right. All right. Next question. A 17-year girl comes for a contraception, sorry, recently started being sexually active. Her BMI is 31 with opportunity screening can be done for this patient. So just a 17-year but bit obese, recently started sexual thing. So which one do you think is more important? Uh, Looking into blood sugar, diabetes, eating disorder, or PAP related thing. So which one do you think is more important here? So it's a more important that you talk about the obesity and all this thing. Okay, so that's very important. Say example, uh, if this is the same one, and if I just cut it down and make it as a 18-year, let me cut the BMI like a normal, and now add in another option, uh, blood pressure. What do you think now? Okay, sexually active, fine, and come for screening, and sugar, eating, PAP, and blood pressure checking is there. Now, which one do you think is more important? Answer is like a BP, blood pressure, actually. In that case, it is a MC handbook, or someone saying Blue Book also has a similar kind of question. In the beginning of Blue Book, there is a similar kind of question present. So if they would have been mentioned in the previous question, like you like to do some of the STD screening or talk something more about the STD. Okay, in that case, STD screening, you can go for the previous question. Why BP? Please read John Murtak, you will understand why actually. If you look into that, like like when we start blood pressure, I mean now have to go to the basic. When we start our blood pressure checking. Now we doctors we don't check our blood pressure, I think, often, but what is the age for start checking the blood pressure? It should be started from the age of 18. So if you don't find anything, so you should start checking the blood pressure among others. You should start checking the blood pressure. All right. Okay. So check some of the early pages of John Murtak, page number 70 to 80. In between few screening related things are written. Talking about the previous question. Now coming to this question, and a very popular one: gestational diabetes mellitus. Please take a note. Gestational diabetes mellitus is a 5-star. Women with a previous history of gestational diabetes mellitus resolve after the birth. Come to the GP. What is the advice? Lovely. Good. Keep going. Keep going. All right. So, like a postpartum testing and long-term follow-up. So, it is important to all women to have a gestational diabetes, have an OGTT to clearly document their glycemic state after the pregnancy, using WHO criteria diagnosing the particular disease. All right, let's come back to this question. What they're trying to say: women with a previous history resolve after the birth now came to the GP. So, please check: is it a is the patient is coming during the pregnancy, or is the your patient is coming after the pregnancy? Please note that one. Is your patient coming during, just after the pregnancy? It's the patient is coming after the pregnancy. Always check carefully in the question, because you might get confused and ended up with some wrong answer. It's a very common mistake by many. So here is the thing. This is a case related to postpartum testing and follow-up. So postpartum cases definitely need to do a gestational diabetes. Quick question. During pregnancy, diabetes, during pregnancy, hypertension, is that thing is a common thing. If during, we'll talk about it some other day, it's a very big thing. Or you can search in the RSCGP for now, gestational diabetes mellitus and RSCGP, you'll find that full one actually. Okay. You'll find the full one, my dear. Yeah. Or you can check our obstetric note. It's given in the beginning of the obstetric notes. From the very beginning, point is discussed. Gestational, like so. Just check in our notes section. Go to the SMA notes. Open the obstetric notes. The very first slide is a gestational diabetes. Okay, so you see certain other points. Some other day I will talk about that one. Okay, it's a little bigger thing, gestational diabetes. So don't worry, it will we'll bring that one in the class. All right. Just taking a second, guys. So last year, out of I was talking to my class monitor, I was talking to some of the candidates. Which system question has been increased a bit? What do you think? I mean, other than what we read and the things, other than psychiatry and ethics, which one thing people feel has been increased, like other than the psychiatry ethics, that's keep coming. Ortho started increasing from the 2022. So that's already is there. Okay, so surgery, yes, well done. So surgery, some questions, like a general surgery, some question has been increased. Ortho has been already increased actually. So some general surgery question has been increased. That's why we took even last recall batch, we took one or two special classes on the surgery, right? If I'm not mistaken, actually, if anyone is there from the previous batch. So we took a one or two special class on the surgery, out of the box, actually, like some new general surgery questions. We'll try to also add that one. Also, I try to add that class. At the same time, we also notice some questions are coming from the infectious disease. Will you agree? Those have been following. Some of the infectious disease questions are also coming. All right, so I'll just taking a second just to bring something. STI, I mean, that's not a system, STI, or but infectious disease. Yeah, don't worry. Ortho, usually we do take a class in between. Last time we also take one, I think. Don't worry. We are flexible. Sometimes ortho is always tough. Yes, I know. Even if you check the bonus, like let me tell you, in the last um, particular batch, let me show you. Not sure it's there or not. Or bonus files. See, ortho one is there. So in the last recall batch, we also took a ortho recall already for you. Right. So you can check that one. If necessary, we will also add that one actually. Endorhemato. Now, thing is there. I mean, endorhemato. That's like in general, we have to read it. Like, I mean, those are from our 5 months batch and the things. We already go through in very details rheumatology, very details endocrinology. So that's not a big problem, but more new questions that keep coming actually. That's sometimes matters. So general surgery, I think we'll take a special class in this recall course, no problem. Some additional things are also given. If additional thing people demand, we add that one. So some demands are coming regarding the infectious. After the November one, we talked to the class monitor and the things. We also have a teacher, Dr. Rafid, he was also mentioning that, some infectious probably is increasing. Also, I talked to the class monitor. So I think, it's better that some of those new questions on the infectious, we should also have a look actually, because in 5 months, I was not separately including the infectious actually, but it's time to add some of the infectious things actually. Okay, someone is asking, sir, how to study and plan notes. Okay, before getting into that one, let me show you how to do that one. Actually, if I show you the routine in the next class, actually bring that one lecture on the SMA notes, how to use and material demonstration. So I keep that one. Today is like a trial class, so that's why I kept that plan for tomorrow actually. That how to utilize now. I can tell you the basics, but let's bring those things tomorrow would be more better. Okay. So, anyways, let me bring out. That's okay. If since someone asks, I'll just take a 5 minutes. But next class, I'll talk about more detailing. So don't worry about that one. Um, but for basic now, I will tell that one. Uh, there's a two question depends actually. One, are you attending our class for the first time, or are you from our like previously was in our 5 months course actually? So we have a two group of doctor actually. All right. So here is the thing actually. We have a two group of doctor actually. Are you attending for the first time? Yeah, that's the thing. Okay. Second, so our classes are mostly Monday and Friday, if you see, and just follow the routine. This will be your routine actually. So routine is based on the Monday, Friday actually. Okay. Talking about this thing, I mean, are you with us for the first time or previously our student? Because some people renew and come, some people were in 5 months course and then come, some people were in recorded course and they come up actually. Some people came for doing more recalls because they don't have a study partner, they don't have recalls. So, all right. If already from the previous batches, you already know about plans actually. Okay, that's the thing. If it is the first time, there's a question that comes. Okay, so question to those people, those are attending first time, have you solved some like chapters from the John Murtagh, and have you finished the MC handbook plus any uh, maybe a little bit any offline question bank or anything have you finished and then came to us? The first question, if you are with us for the first time, have you finished some John Murtagh chapter by yourself? Have you finished like a 50-60% of your handbook? And have you started some question bank recently, like a bit? Yeah, so that's good actually. Anything, Amedex, Mplax, or QBank, anything. So if that is the thing, then you are the right candidate for our recall course. Now I can give you some plans actually. Yeah, those are already from our batches like a course T, regular batch. They already know about us. So it will be more easy for them. Okay, if someone is having only handbook, your preparation may not be that good actually. So Dr. Asmatullah, you can contact me later. Yeah, contact me later. You might need more plans actually, my dear. Handbook is nothing. Handbook is like even a medical student can read those 500 questions. That's we don't call AMC preparation. You might need a more theory preparation. So if someone is reading those things, solving Amedex and handbook, quite a half-hearted preparation. So in that case, I'm coming to those points like how to take a proper preparation. So if someone is with us for the first time, then what can be the plans here? So the plan is actually check the SMA note for the theory. Clear? To cover up some of the theory, the note we gave, or you're planning to take admission, will give you the notes, the full set of notes that will cover a lot of portion of John Murtagh as well. I mean, those are more bullet. So while preparation, just before the exam, those are like a very cool things actually. Then comes, the recall solving. We call it like a pillar actually. Okay, for in any general preparation for MC, remember like a four pillars actually, like a theory, then what? Recalls, then what? Theory, recalls, mocks. Yeah, yeah, notes are included in the course. Mocks, question banks. Okay. So that's how the theory you can cover from books, theory you can cover. If you have SMA notes, you can cover. If you have our lectures, then it's more convenient and easy. That's the other thing. So those for the first time with us, cover the theory from the SMA note. Sometimes you can open the John Murtagh, that's also okay. Recommended side by side, you can open the page numbers. Example, ENT today mention, you open it. It's like that actually. Can we cover the theory from the SMA notes only? Depends on if you're in the recall batch, you don't have much choices actually. So that's you can go with the our notes in that case. If you're already in our theory batch someone, then of course there will be theory classes would be there that follow the theory class instruction. Okay. Recalls here in this batch, there's so much recalls, like a 1 year live we are doing. So here is option like a 4 years. Now talking about that particular, now this is should be the also your part of plan. Now, if you are examining of March, say example, every 15 days, try to solve one particular year. Clear, my dear? Every 15 days, let me give you a plan here. So I'm telling here now. So from second to 15, uh, try to solve the 2022. Okay, no problem. Then 16 to say 30th, try to solve 2021. Then let's say 1st February to so 20th Feb, you try to solve the 2020 in that way. All right. So this is how you can plan a little bit. Okay, let me highlight. Okay, and talking about the 2023, and technically, in this, like we started this 2nd January to, say example, till the first week of March, whatever it is, we'll be already solving your whole 2023 and 2024 upcoming, correct? So those, you can solve easily with our live class. Clear, guys, I'm not able to see the chat box now. It's so many questions actually. We'll come back to that later. Great. So, or you can leave me an inbox message. We can come up with that later actually. All right. So here is the plans actually. So did you see these plans, guys? Did you see these plans actually? So you can follow up in this way. So already, because we are doing it live in any way, 2023 and 2024, we're going to do it live in any way. Right. And those from the drive in every 15 days, or depends on your exam. If it is in April, you can increase the time a little bit more, maybe extra at 5 days from 2nd January to 20th and 20 to 10th. So you can make a permutation combination of your own if your exam is in April, May onwards actually. Or if your exam is in say May, then every month try solve 1 year. Clear, everyone? If your exam is in May, in that case, every month try to solve one of these folders. Every folder has, if you see, all these months actually. Yeah, we do have, of course, monthly recall file. Someone is asking, so we do have monthly recall files and things. That's why I do here. All right. Okay, no tips for no. We are not focusing on February, my dear. So we're not focusing into prepare of your own actually. Solve as much as possible. Solve everything as much as possible. Actually, no tips for February candidates. Okay, we are targeting March, April, May, June, those things actually. February, we're not focusing right now actually. If already our student, there would be a support group during February. That's the thing. How many years recalls? Because being difficult, at least we recommend 3 years to solve at least. Okay, great. So these are the particular things. So follow them accordingly. And there will be live classes already. In these live classes, we'll be solving these things. We'll be solving these things. Alongside these things, try solve the SMA notes from the drive. Along with these things, try solve the SMA note from the drive. So drive has the SMA note alphabetically. If you go whenever you're studying medicine, quickly finish them and this, that. So in that case, you can just follow them. No, it's not a pre-recorded, it's already, we are taking the live class. Of course, 2023, we are taking again live. And of course, the supports are given actually. 4 year taking is not an easy thing. You take one class, then you can tell how difficult it is. All right, great. Okay, any other, I think questions, too many questions are coming. So these are somehow the particular part of your plan. We'll talk more about. like, some of the other things very soon. I think I would recommend Dr. Rafid to share the screen because I just came from country. Dr. Rafid will take few things about the infectious disease. I requested him because, I just came and even haven't met the family in that way actually. So let me just turn off my yes. Hi, Dr. Rafid. How are you doing?
Hi, Dr.
Great.
Shahriar. Yes, ho-
All
hopefully
right.
I'm okay.
So yeah, you're okay. You can share the screen, and by this time I can talk to them and introduce you shortly. So, thing is, guys, I mean, in recall class, of course, I take classes. Dr. Rafid will also assist me in some classes, and I was also talking to Dr. Rafid, like some, and also class monitor, that we figured out some new infectious disease questions has come. All right. So Dr. Rafid will take 1 more hour class to with you guys to solve some infectious disease. As I mentioned, other than these routine things, sometimes we also um, do solve actually some complicated thing like orthopedics and additionally few things. All right. So I think it would be helpful for many and enjoy that remaining 1 hour class with the infectious. I'll see you guys in like, on, I think the routine was given. Second routine on 5th, I'll see you guys again solving the more questions actually. All right. So for now, I'm telling bye because I just came and just landed last night actually, even having, time zone thing, differences. So I'm quite having a dizziness right now, but job comes the first. That's the thing. Didn't miss the class, and hope to find you in details class on 5th definitely.
Dr. Shahriar, can you
And
please see the screen about infectious disease?
yeah, I can see the screen, but maybe your infectious file didn't came yet actually. So you need to reshare that one, like
Okay,
share
okay,
the
okay.
screen and yes, that one.
Okay, I will
Yeah,
reshare
you
it.
can yeah, you can reshare it, no problem. Yes, and drop me those messages, guys. Those of you who are new, drop me messages. Maybe after taking a little rest, I will definitely get back to you guys. Actually, I can see the infectious disease file straight away now. Actually, Dr.
Okay,
Rafid,
okay.
he cleared his exam recently, and congratulations to you. I mean, again, congratulations. I mean, it's in last recall batch. He also assisted in some classes actually, so he got good review on that one. And yeah, so here we go. And the orthopedics was his idea actually to add in another orthopedics class. I think we can also add that class actually, even though the recording was there, but we can add that class again actually with this batch. And of course, like Biostat, many doctor requested to have a live, so we'll also go for a Biostat live. So other than the routine thing which we have shown you, I'm going to post that one in that our batch 54 and guideline group. You can see that routine, what are the things come. Other than those classes, we also help you with a lot of things actually. So don't worry about that one. First of all, do not panic. We are with you and you don't get panic in the exam. Panicking only can make things worse actually. So take as much as preparation possible. Those are busy practitioner might need a separate management. We'll talk about that one next day. Study is the only key in MC. I'm telling you again, study is the only key in MC. So please make sure that you keep studying. Try to study 5 hours a day, 5 days a week. Normally we say 5 hours a day, 5 days a week for 5 months. Here we have less time. So at least study 5 hours a day, 5 days a week. At least for 3 months you study. And in the last month, it should be more, not 5 hours. In the last month, you should study the maximum. All right. So that's very, very important. All right. So keep going that one, guys. I'll try answering some of those questions. So do not worry, actually. Someone asking how to take admission, drop me a message in the inbox. We'll come back to you probably tomorrow. Okay. Someone asked about how to proceed, how to admit. You can drop us a message tomorrow. We'll definitely let on. Please note we have two types of courses just started. One is for the beginners, that's the 5 months course. We have a theory class and the recall class. And this is specific for the recall that those already prepared with John Mutta question bank, but is still lacking recalls, still lacking study partner, or even finished a 5 months course, still not everyone is in the same board, not feeling confident. This will give you more confidence in the exam during. So 3 4 years recall is a quite a big deal actually. All right. So good luck to all of you. See you on 5th actually, with the recall class again. I'll see you guys on 5th. All right. Thank you guys. All right. So
Welcome, Dr.
tata bye
Shahriar.
bye for now. Yes, thanks, my dear. All right.
Okay, everyone. Can you please hear me? Just a shout. Yes. Okay, okay. It's okay. So, uh, infectious disease. This thing is totally new for you guys because first time we are introducing this to you. Because in previous year we faced a lot of question from infectious disease. Yeah, we know that infectious disease is huge, a huge part of medicine, but we'll try to make it short, and we also collect some of the questions that will help you. In my exam, I also got 2 or 3 questions from infectious disease. I remembered at this moment that I got question like giardiasis, and then I also got question like cystosoma. So you can say these things are important. No one gonna a small break. Everyone need small break.
Oh, I think I or forget to give them a break. I think, maybe a 5-minute break for the prayers can be good, I think. But, thing
Okay, okay,
happens
okay,
sometimes some people go away, after the break, people often happens that. But
okay,
Williams
okay, okay.
come, those people, yeah, so that's the thing actually. I mean,
Then we'll
Williams,
run our show after 5 minutes. 5 minutes break for
oh,
everyone. Okay, okay, that.
we trust you guys because some people run away. Give it like less, like a 4 minute, 5 minutes
Okay,
break
okay, okay,
actually.
okay, okay.
That's
Then
okay.
4 minutes. Okay, 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 okay.
You can keep talking about them, like those wanted to interested and ask about preparation. Maybe you can keep talking to them
Yes,
or
this was
keep suggesting
okay,
them
okay,
few
okay.
things by this time. And the class you can start maybe after the 5 minutes actually. Yes. Yeah, yeah, we'll post that recording. Don't worry.
Okay,
Don't worry.
then 5 minutes break. And guys, if you want to ask any question within five
Yeah, yeah,
minutes,
feel
I
free.
will give you
Like,
the
some,
answer.
yeah.
So you can
So
please.
some of this technical questions, guys, you can also ask. Dr. Rafid also cleared MC1 recently, so he can also guide few important questions, like like a technical things, and this particular thing. So don't worry, actually. All right. About the admission thing, please inbox us. I mean, inbox in my Facebook. I will definitely answer you back after taking some rest. That's the thing. Yeah. So someone straight away with your question to
Study
you,
plan.
Dr. Rafid. How was your study plan? Okay. So now answer this one. It will take 5 minutes for sure.
Oh,
All the best to you.
okay.
All right. All
Okay,
right.
okay, okay. Nice question. How about the study plan? Someone asking about, can we do this course? Okay, please. Is May good month for the exam? Obviously, May is good month for the exam because you will get recall from February and March. Oh, obviously in April, 3 months you will get a ton of recalls. So obviously May is a good month for exam. And someone is asking for the plan, preparation plan. Okay. Uh, for July, should I wait for the next batch? Yes. Okay. If you have any problem, you can, of course, you can wait. But what about March, for example? Obviously, good for exam March. Oh, little bit tough, but obviously it's doable. But if you think months like June, July, you will face some tough questions for March. Yes, it's difficult, but you will get 2 or 3 question bursts in the next month, like April, May. You will get ton of questions. What about April? Obviously, you will get the recalls there in April. Okay, someone is asking about the preparation things handbook, like question banks. Look, the thing is you need uh, what you need obviously you need the strong base in your theory, uh, uh, because you're not gonna get direct question from question banks, from handbook or anywhere else. But if you have a strong theory, you will penetrate all of the things that you will get in the exam. Which question bank do you advise? Anything, Amidex, M plus X, anything. You can go through it. The thing you have to do, you have to get the concept from there. Okay, only the concept. Someone is talking about some study plan in February exam. Okay, if you booked your exam for February, it's just knocking at the door. Try to revise all the things. It's time for revising things. Okay, try to revise it, go through again and again, try to mix up things. Okay, this is much more important. Is amedics enough? Look, nothing is enough. You can say amedics is the ideal things. You can say M plus 6 the ideal things. What you have to do, you have to extract the important things from the there. The important things means the conception. You read those things for 1 or 2 times, 3 times, whatever, but you have to extract the knowledge and the concept from there, because you're not going to get the question directly from those things. Which month is best for any month? April, May, all of the same, but we saw some difficult question in June, July, especially in June, or in the first months like February, because you don't know what happened in the first, because it's the first month of the year. So I prefer, okay, April, May, everything is okay. April, May, September, October, everything is okay. But try to keep yourself away from June. Yes, what about July? I give my exam on July. So what can I say about July? It's you will get in every exam you will receive some of the tricky questions. Okay, that tricky question you have to answer them. You're not gonna leave them. So in exam you have to answer all of the questions. How to make study plan for beginners. Yes, you're right. Go with theory, handbook, question bank, because if you can blend up all of those things, it will take minimum 4 or 5 months. Uh, There's the thing. So I think we should start, because uh, can you guys hear me? I think we should start now. So ready, time to bang up. Okay, here we go. Our first questions. A 40 years old man presented with TDS is versicolor. What is the most appropriate treatment? Can anyone please give me the answer? Like methotrexate, oral terbinafine, PUVA, topical selenium sulfide, and phototherapy. Everyone is giving the answer D. Okay, okay. Okay, we'll start recording. Just give it. Everyone is giving the answer C. So why do you guys think for the TDS is versicolor you want to give the ultraviolet ray? Look at the question first. What is the most appropriate treatment? Okay. So I think we should, for the treatment purpose, we have to go the first line here. Because if you use all of those things, if it doesn't work that time, we'll go for the other things. So here the answer is topical selenium sulfide. Okay, topical selenium sulfide. And why we give that answer? Because this is totally from the John Murtagh. Okay, this is from John Murtagh. Be careful about it. I think we can give you the appropriate reference in every time. So this is the thing that please. So iconazole, ketoconazole, selenium sulfide. This is the answer. This is the answer. So we all know that all of those things is related to the azole, but at this moment, because azole is not in our answer, you guys can see. That's why we are giving this selenium sulfide. Okay, I think we are going for the next question. Which of the following suggested diagnosis of molluscum contagiosum rather than chickenpox? This is the different things. So be careful about the things. I think you should keep your notepad aside of you. I want to tell you something regarding to this. So infectious disease question will always come. What is the diagnosis? You will receive 80% of the question that will say what is the diagnosis. So be careful about that. What is the diagnosis? Everyone, they will ask you that question, specific question, what is the diagnosis? So we will receive a ton of question from different things, but the main question is about the diagnosis. Then we'll give emphasize on the management things. But be careful, I can say that you will receive one or two questions regarding this, what is the diagnosis. Okay, so everyone is giving their answer B. And here we go. The answer is absence of erythema surrounding lesions. Everyone here is right, because what is the thing is chickenpox. We will found that tears in the rose petal or something like that is containing a clear fluid inside of this, so no sorts of redness. But molluscum contagiosum, we can see the erythematous things. Okay, so that's how we can differentiate that. If we saw this, that will help you. Look at this, the related things, the rashes things. We can see this rash related chicken pox, because no redness around there. But things like erythema, we can see a lot of redness. So be careful about that. Easy question, but you have to be specific. Okay. You can also read the things like herpes, molluscum contagiosum, varicella zoster. So one thing I can also add there, please write it down. Uh, they can ask you anything from there. Okay, they can ask question like about schooling things. How many days the school of the boys will need, or the baby will need, or the child will need, because we are seeing molluscum contagiosum. Common question you will receive in the exam about the school holiday things. So be careful about that. Question may kind anything may come. Okay, so we are going for the next thing. 10 individuals are admitted with causality with the profuse vomiting after attending a retirement dinner in a Chinese restaurant. They all ate at roughly 7 p.m. and became ill at roughly midnight. Quite things. 9 ate maximum of dishes, except one female who ate vegetarian dishes with her rice. What is the most likely infective organism? Okay, now it's time for the answer. Salmonella, Staphylococcus, E. coli, Clostridium, Bacillus. So someone is telling Staphylococcus, someone is here saying, okay, someone is telling E. Yes. It's time to reveal what is the appropriate answer here. So it's Bacillus. Because tricky thing, look, try to grab all the key points. It's your duty, try to grab all the points. Yes, someone saying is rice. Yes, the thing is, look, there is the thing is rice. Here is the thing is vegetable with rice. So be careful about that. Okay. And anyone can say about the time length. Because you are taking your dinner at 7 p.m. and within 5 hours, you are having this type of conditions. So we can also say there's a very short incubation period here. Okay, look at this, only 5 hours or something like that. So I think you're all getting the answer, because this culprit is related to the rice. Okay, Bacillus cereus. So what we are talking about, Bacillus cereus. Here is the thing. Look, cause food poisoning. So they are all the food poisoning. Spores survive cooking rice. So all we are talking about the rice. So try to be specific in everything. Hopefully it will help. Be specific. Try to find out the buzzword. I always told about the buzzword things. Okay, be careful about that. I think you are getting your answer. Yes, we are collecting all the reference from John Muttag, PubMed or anything, but from something came from the USMLE things. But the thing is, for infectious disease, we have to search a lot of the websites because this is not in the book. So we try to find out the answer and just grab those things. Okay, might be some from the PubMed, might be some from the USMLE step to CK. Okay. Yes, that's right. It's first aid. Okay, we're going for the next question because I'm also saying that because we are introduced this thing for the very first time. So it's very difficult to collect all of those references because it's not from John Murtak. Yes, you will get some questions from John Murtak, but rest of the things you have to find out in other websites or books. A 27 years old man present with fever, urethritis, arthralgia is found to have a swollen ankle with pustular rash and the dorsal aspect of his foot. What is the most likely diagnosis? Look, we are all talking about these things. Okay, we're all talking about that they will ask. In 80% cases, they will ask about diagnosis. And here they're asking, someone is talking about the Lyme disease, someone is talking about the Raynaud syndrome. Okay, so triad, yes, doctor, you're right. There's the triad. So when we will get the triad, it's fever, urethritis, arthralgia. So another thing is missing in this triad, but hopefully we'll getting all of those things. Carl, can you please tell me what's the missing? Something is missing, but yes, uveitis. That's the thing. Something is missing here, uveitis, but we are getting all of those things, especially urethritis, the most important things with arthralgia, and every infectious condition will get the fever in free. Okay, so that's now we'll see the things. The answer is Raynaud syndrome, and here it is in front of you: asymmetrical arthritis, conjunctivitis, and urethritis or diarrhea. Okay, hopefully you are getting it. Very much common question for your exam. Anyone will get it. Common in AMC circuit. So be careful about that. No need to do hurry. Okay. So we are going for the next thing. Everyone is aware of the triad. Thank you very much. This one, we are getting a stain here. A 63 years old female present with a one-day history of confusing with headache. On examination, she is confused with a Glasgow Coma scale 13 and a temperature is 39.5. So the temperature is crossing the level, but in the GCS, it's kind of normal. She has nuchal rigidity and photophobia. So can you please tell me what happened here? The nuchal rigidity and photophobia. CSF examination reveals glucose 0.5 millimole, a white cell count is 5,000, and a gram-positive cocci in pairs. Meningitis, and they are also said the gram-positive cocci in pairs. Diplococcus or something like this, that will be in pairs. So which of the following is the correct? Okay, you will face this type of question, one or two. Which one is the correct? Which one will be the, which one is right? Which one is false? Which one is not true? So be aware of reading question. I prefer that, yes, I think you should first read the question, what they're saying, which one following is the correct, which one is the false, which one is not true. So be careful about that. Okay, then we are coming for the most likely infective organism is Staphylococcus aureus. The organism is likely to be a penicillin resistant. A rifampicin should be given to close contacts. Then liver deafness or nerve deafness would be a common complication in this case. A characteristic rash would be expected. So someone is talking about the meaning of leukemia. They're in this stain. They are not revealing these type of things like rashes or this thing. They're saying that confused, the rigidity part, the photophobia, the common one. But they are giving us the clue that gram-positive cocci in pairs. Okay, because previously we didn't see any type of things in the question like they're giving us this type of clue like gram-positive cocci in pairs or with meningitis. Okay, so that's why I saw someone giving that answer previously. The answer is B, organism is likely to be penicillin resistant. So that's the thing. We are getting it like someone is talking about the patient confusing with low GCS will be considered as encephalitis or meningitis. So look, encephalitis, you will see other features. Okay. But here, because there, what you have to do, nice question. First of all, I want to say something. When you will read the question, it's important. It's very, very important for everyone. When you will read the question, try to set one of the provisional here. Okay. From the reading of the question. Yes, you are reading it. That one probably the professional. Yes, previously I asked that, what do you think? First of all, you think is this meningitis or encephalitis or something like that. Reading it, I think that this is meningitis because they're giving two or three important clues, like what the clues are: nuchal rigidity, photophobia, and the temperature. Okay, this is the clinical things, and after that they are giving you the lab things. So you can say that this thing is like the meningitis things, and with the lab you will confirm that. So be careful about that. Yes, the thing is, your question was that whether it was meningitis or encephalitis, because if it was encephalitis, the GCS will be low. It will not be in normal state. And they also add some of the things like the liver enzymes and others things. Okay. So be careful about that. Try to knock the most common one first, then the rest. Yes, you can use the process of elimination here. So the answer is the organism is likely to be the penicillin resistant due to the positive cocci. And here we can see the references. Yes, we got this reference, same references from John Murtagh. We just added it from the John Murtagh. You can also see that the most important things, CSF findings in meningitis, this, believe me, you will get one question from here. In every exam, whatever it's AMC, USMLE, PLAB, everywhere you get one or two questions from this table. This table will contain definitely one question. Okay, so be careful about that. What questioners saying, just flow it with that. Now, okay, someone is talking about the why it is. Okay. That's a good question. Okay, so we can take this question as a standard question. So here we can see the things look like that. This most likely the infective organism is Staphylococcus aureus. So from the try to use the process of elimination tricks here. Okay, so they are talking about the positive cocci things, because from that we can say this one is not the answer. Rifampicin should be given to close contacts. So we are all know that all the meningitis things will use the drugs like ceftriaxone is the most common one. You can check it in the John Murtagh because it's written there which type of drug we will use. Benzyl penicillin we can use, but etc. like of drugs. Then never nerve deafness would be a common complication in this case. Uh, we are talking about the meningitis things, or from where these things type of herpes-related things came from. So we can exclude that. Then we are got only two or three things here. A characteristics rash would be expected. Okay, we are talking about the meningococcemia or something like that. We are not in the question. We are not getting any type of things because they are always talking about the diplococci or something like positive diplococci or something like that. So be careful about that. Here we use the process of elimination here in the question. Okay, so AMC will judge you this way because they want to judge your knowledge here. They will not give you the all time. They will not give you the proper theory. In the question, you can see. Yes, gram positive is so no meningococcal. Exactly, that's the thing. So be careful about that. They are judging you here, not with the theory, because they give you all the things you needed. But they are create this answer for you because they want to check your process of elimination things. If you want to use that, you can get the answer here. So be careful. I think everyone is clear now how we will eliminate the question. Sorry, how we'll eliminate the wrong answer here. Okay. And this type of question, which of the following is the correct? When you will get this type of question, please, I'm requesting all of you, go for the process of elimination. Otherwise, you're not going to get the answer. Only for this, they are giving you this type of questions. Okay. I think everyone is okay with that, how we eliminate all the things from that stem one by one. I think this is very, very good example for this, how we'll use the process of elimination. Okay. Hopefully everyone is getting that. Okay, another question regarding meningitis. A young teenager present with fever and headache, he has received oral amoxicillin for 3 days. Which of the following CSF finding would exclude a partially treated meningitis? Negative gram stains, CSF glucose 45%, a white cell count of 50%, a negative CSF culture, and a negative chronic signs. So what do you think? What do you think? Please give your answer first. You can give whatever you want to give. We'll talk about that. Someone is say B, someone is here is D. A culture, okay. Someone is saying a negative CSF culture. So after 3 days, because you have to take the culture report within 40 to 72 hours. So it's not matched there within 72 hours because if you take the report in the very first day, you will not get the answer. Probably that time you will get what you will get, the positive things. Okay. So that's why be careful about that. They are playing some tricks there, a negative CSF culture. Okay, how do you think after 3 days it will become negative? Okay, be careful about that. So I think someone to previously someone is talking about the B. So I want to know why you were, doctor, can you please tell me why you were giving the answer B? Why? What do you think about that? Why it's B? Because when we will see the answer, the right one is CSF glucose of 45% of blood. The thing is, this is the trick. This is the trickiest question. So if you can ask me that, doctor, should we read all of those tables or everything from the table? I say, yes, you have to read all the questions from the tables, all the lines from the tables. But be careful. They're judging you with the concept, not the questions. Okay. Here, the thing is, we all know that previously the huge percent of meningitis occur with bacteria. And we know that bacteria take glucose as their living things. So what happened if in the very first we saw that this meningitis occurred with some bacteria? That means they're using your glucose. So the number of the glucose will reduce in the very first. After a few days, when you check the CSF, you find, okay, we are treated it half. Now the number of glucose is raising. This is the trick, doctor. This is the trick. Be careful about that. Again, they are telling you which one is the right or something like this of things. Okay, this is the things. Here you can see that the glucose level is here. Glucose 50%, raise more than 50%. Acute bacterial case, decreased than 40, raised than 40%. Tuberculosis, less than 50%. So you can say that this is not TB or something like that. You can say that is, yes, it's a bacterial case. Now the amount of glucose is rising. So I think, guys, you're clear about that. Be careful. AMC will judge you. Anyway, do you think this question came from the handbook or the probable things like the question banks? No? Yes. But you read a lot of questions regarding this from there, from question banks, from handbook, from your notes. But what you have to do, you have to keep some residual part in your mind to figure out these things. Okay, negative chronic signs within 3 days is not possible. A negative CSF culture, for the culture you need to much more times. White cell count 50, negative gram stain. So within 3 days, nothing is possible here. But one thing is possible, like there is a 40 to 45. They are increasing these things. So I think you are all getting the explanation. Hopefully you are clear with these things. Okay, our next question. Which of the following statements is characteristic of acute hepatitis B infection? So, first of all, we have to figure out how hepatitis B is spread. We all know those things like blood, semen, from drugs, pricking needles, etc., etc. So from that, we can say that answers, everyone is going for the answer. There is increased infectivity in the presence of the E antigen. Okay, if you are all giving you this one is the answer, it's not impossible that that's not be the answer because this is the answer. Everyone here is right. They are all giving increase the infectivity. That means increase the number of antigen in your body. That will causes a lot of chaos inside of your body. This one is easy one for you guys. So when you will get this and this type of question, just kill it. Okay. Okay. Here's someone giving the answer first or the question first, but we have to discuss it. Which one of the following is the correct in Giardia lamblia? Infection is often symptomatic, usually spread through the droplets, eradicated by metronidazole, cause trattoria, diagnosis by stool culture. So the thing is, we don't know because that's why we are getting the answer first, but we have to discuss about this question. This question is very much important, guys, because they're gonna ask this question in several ways. They can ask a guy from they can travel from Middle East, they can travel from Southeast Asia. They took some of the street food or something like that and came with the foul smelling which floating over the pan or something like that. Be careful about that. Stratoria is the main thing for this. Okay, so always they will ask you two questions. What is the most common thing here? And what is the probable diagnosis? In my exam, I faced that question. That was they asked for the diagnosis there. What is the probable diagnosis? They give all the things related to stratoria. And this question, they're asking for the symptoms. Okay, so be careful about that. Cause of stratoria is the must diagnosed by the stool culture. Diagnosed it obviously you will get it D or U is both, but for this thing we are gave the answer E because it's the most common things, because with this criteria you can clinically figure out the things. Okay, so here with the thing, I think we are all getting the thing. Always go for the clinical things first, then the other, then is investigative things. So here we can, what we can do, we can eliminate all the things because they can give you the things is correct. So if you get this type of question, go through all the options first and then eliminate it one by one. Is often symptomatic. What do you think? This patient is often said every time you will get this type of things. Is usually sprayed through the droplets, is fruit particles, not through your respiratory droplets or something like that. So one by one, you can eliminate all the things. So I think you are getting it. This question is very much right. Or someone's talking about this stool antigen, not stool culture. Exactly, this is the thing here. It's for the E because we're not doing stool culture. It's stool antigen. That's the thing. We can probably find out anyone here from the microbiology, because we thought the Giardia lamblia probably racket-shaped things or something like that. I think that was probably written in our microbiology books because probably it's probably in racket shape or something like that. Yes, it's a parasite. So for the thing, this type of question, I always tell you that always go for the always go for the diagnosis first, then other things. Go for then symptom, then management. And someone is talking here about the treatment things. Yes, we can obviously say the metronidazole here. In every cases, we can use this type of parasite things. We can use that metronidazole. Which of the following statement is true? Again, this type of question, stachosis things. Be careful about this. This is not very common question. We got this question from 2021 because it came. So we add that it's only a risk from the contact with the parrots. It usually causes many polymorphs. It is more of a risk of children than the adults. It does spread from person to person. Infection responds rapidly to penicillin therapy. So I think this question is not much more common. I think we should go there. It is usually causes of many polymorphs to be present in the sputum. So this one is the thing. What is that statement is true? Okay, so be careful of it. It is usually causes many polyforms to be present in the sputum. So we got this question. This one is very, very old question. But what we gonna do? We have to add it for you guys. So you can just go through this. Look, I want to say, if in infectious disease, you will not get ton of questions, but these 2-3 questions can change your luck. Okay, so try to get all of those questions, prepare your notebook for this. Hopefully it will help. Okay, the next question, the important one. We're going for this. Which of the following statement is true in infections with Mycobacterium tuberculosis? Okay, this one is important here. Can non-sputum producing patients are non-infectious? A positive tuberculosis test indicates active disease. Lymph node positive disease requires longer treatment than pulmonary. In the pregnant woman, treatment should not be given until the delivery. Pyrazinamide has highly activity against the active organism. Okay. Anyone here is saying the C. The thing is, how you guys say lymph node positive disease requires longer treatment from pulmonary because okay. So from one of the things we saw that someone is giving a positive tuberculosis test indicate active disease. Okay, the thing is, the non-sputum producing patient are non-infectious. Obviously, how can that be true? It's false. It can be infectious. You may have sputum or not. So we are talking about what is the true thing. Then a positive tuberculin test indicates active disease. We can say in many disease, the tuberculin test may be positive or not. But the thing is, we're talking here about the active disease. Most probably it might be latent TB or something like that. Yeah. Lymph node positive disease require longer treatment than pulmonary. Okay. So here, these might be also the things, but we saw that lymph node positive disease requires 3 months, and we gave TB treatment for 6 months or something like that. In pregnant women, treatment should not be given until after delivery. Uh, this is not right. We have to give the things in the very first time. In pregnant women, treatment should be given when we'll detect the TB. After that, we'll start the treatment. And pyrazinamide has highly activity against active organisms. So this is the treatment of the TB, the pyrazinamide rifampicin. We all know that things. So they gave the common one in the very last, and they talked about huge things in the very first. So they are pushing you for read all of the things. Okay. The lymph node positive disease requires longer because it's longer 3 months, and the pulmonary longer 6 to 7 months or more. So how we can say that is lymph node positive disease take longer here? So we can only get this that very easy things. Pyrazinamide has high activity against active organisms. So they give the clear-cut things in the very last. So the answer is pyrazinamide is high activity against active organisms. We all know the pyrazinamide is the treatment of TB. We are using it. So we are going for the which of the following statement concerning zoonotic disease is true? Again, we are getting this type of question. Yes, someone is saying of the thing because we saw that in lymph node it takes 3 to 4 months, but if the TB affected the pulmonary disease, it will take more like 6 to 7 months or more. So that's why we are giving this answer. And when we read all the things in the very last, we are getting pyrazinamide has the high activity against the active organisms, all active organisms. That's why we're selecting the last one, active organism, but the organisms, because it is the treatment of the TB, pyrazinamide. That's why we are going for these questions. Some doctor is saying lymph node positive for 1 year. Okay, doctor, if this question create a lot, I think a lot of confusions. So we'll give you this answer later because we found out these things in the very first moment. Then we will hold this question, the question number 10, and we'll give you the answer later. Someone is saying the lymph node positive for 1 year. Okay, we will check all of these things again. Okay, again, we're going for the next question. Which of the following statement concerning zoonotic disease is true? But the thing is, before answering this question, I have to tell you something because you will find all of these things, zoonotic disease related things in John Murtagh. When something is present in John Murtagh, is must for you. Okay, so go through all of those things like brucellosis, Lyme disease from John Murtagh, and you will get this answer. Brucellosis is characteristic by the neutrophil leukocytosis. Brucellosis is recognized causes of spondylitis. Toxoplasmosis cause visceral larva migrans. Toxoplasmosis causes posterior uveitis. Serological evidence of toxoplasmosis is rare in the adults. Okay, we are getting all the things, but the true things here is like brucellosis is recognized caused by spondylitis because this thing is probably written on John Murtagh. We saw that things in John Murtagh, and we also tried to give you this type things in here. I previously told this thing is from John Murtagh. Try to those things like here we are thinking the artillery related things because if we see any question from zoonotic disease, please go with John Murtagh because they will give you the question from John Murtagh. Okay, so be careful about that. Brucellosis, they can ask you this question. And sometimes for brucellosis question, I previously saw that they give the question like headache or weakness. This is much more important. Be careful about that. The pattern of the headache they will give, and they also give obviously the disease is infectious disease or something like that. You will get the fever free there. So be careful about that. Try to find out all the questions. Okay. So we are going for the next one. 42 years old man with advanced HIV diseases presented with a tonic-clonic seizure. He had been diagnosed with HIV 10 years previously, but had elected to take antiviral therapy. A CT scan on his brain showed centimeter ring and lesion in the right parietal lobe. What is the probable causative agent? So at this moment, they are talking about the causative agent. So previously, we talked about 2 or 3 things. They ask you the diagnosis. They give you the symptoms. And this is the deepest thing. They will give you the what? They will give you the causative agent. Now, for this question, you are getting this is Cryptococcus, Mycobacterium, Mycobacterium tuberculosis, pneumocystis, and Toxoplasma gondii. But how will you set their answer? Okay. The thing is here, it's closely related with HIV. Which one is closely related to HIV? 42 years old man with advanced HIV disease. Okay, Cryptococcus neoformans, someone is telling that. Then they are saying this is presented with a tonic-clonic seizure. He had a diagnosis with HIV 10 years previously, but he elected to take antiviral therapy. Okay, probably he is now on antiviral things. So the Next thing is come 2 centimeter re-enhancing lesion with right parietal lobe. What do you think? Which one create the ring enhancing lesion? From this, which one create the ring enhancing lesion? Okay, yes, tuberculoma. One is right here. Someone is saying that toxoplasmosis. Obviously, the thing is toxoplasmosis create the ring enhancing lesion because they are forcing you with the investigation. Now you can say, why not the other answer, doctor? Why not the other answer? Because be careful about it. Which one is the superior? Clinical or investigation? Which one here is the superior? The thing is, when you will get the investigative things, obviously you will go for that investigative things. So investigation first. So in that thing, we can see that the right parietal lobe ring enhancing lesion. So for that, we are going for these things. And when we are getting this, we will find out which one causing the ring enhancing lesion. And the most common one is Toxoplasma gondii. Yes, we can also see. Now we will correlate the answer with the question because they're saying it with HIV things. That's why we'll correlate with that. So re-enhancing, HIV, Toxoplasma. Be careful about that. Read line by line, you will get the answer. Okay? And try to remember all of those things when you solving recall, which one is much more important. When we will go for the investigation, when we will go for the clinical features, when we will go for the process of elimination. Okay? Be careful about that. So after that, we are adding some features of Toxoplasma gondii, fever, fatigue, swollen lymph node, and can anyone please tell me which patients are much more prone to Toxoplasma gondii? Yes, we have very few questions. After that, we will finish it. Someone is like pregnant, someone here is keeping cat. Okay. There's a thing because previously we received 2 or 3 questions regarding that patient who is also pregnant and had a cat. So you can remember in this way, a pregnant patient with a cat is prone to Toxoplasma gondii. Yes, all of them are right. Okay, we are going for the next one. The question number 13. In herpes simplex encephalitis, which one of the following statement is correct? Brain MRI is statistically normal. Temporal lobe involvement is common. Fits are uncommon. Cold sores or genital herpes are usually present. Viral identification by PCR is non-specific. The thing is, look, at this moment, they are giving you the things, the correct things. So you have to use the process of elimination first. So brain MRI is characteristically normal. So do you think it's normal in their disease condition, in the encephalitis? Obviously, it's not gonna be normal. So what you can do, you can leave it. Okay, fits are uncommon. Fits are more common in encephalitis. So they're telling the wrong things. So leave it. Cold sores or genital herpes are usually present. It might be. It may be something present or something not. Why cold sores or genital herpes? Because it's the very, very last stage of that. Viral identification by PCR is non-specific. So they are all giving the things because through PCR we will diagnose that. So probably PCR is the most specific things. So we are getting all the 4 things. And finally, our answer is temporal lobe involvement is common. So this one is true and all of them are false. So when you will receive this type of question, like which one is correct and which one is not, please go through all the question. After that, you will receive the answer, which one is correct and which one is not. Okay. So I wrote that thing in the summary, how I use the process of elimination here. I again request you, please, for infectious disease, this one will be a perfect way for you. I think use all the process of elimination things. You will one out, one out, two out. Look how we out that. I wrote that in the reference thing. Hopefully it will help. Try to practice in every question. And within, if it's very much common in exam that you will get one or two question uncommon, or three, four, five question uncommon. That what you will do, you have to answer those things. But when you will read all of those questions properly, you will get one or two common things, and you will try to eliminate all of those things. So from five, when you eliminate three, that will be two. 50-50 chance for you, and each time 50-50 chance. For five or six, you will get probably three or four question right. Okay, question number 14. 52 years old, was admitted with measles and leg weakness. Her illness started with a sore throat while traveling in Eastern Europe. Look, the question of traveling is coming here. On examination, she was febrile, 39.1 degrees Celsius, with several areas of exudates on the pharynx and extensive cervical lymphadenopathy. There was weakness of the legs with the absence of tendon reflex. What is the most likely diagnosis? So they are giving you some of the things related to the disease symptom, and again they some give you some results of clinical examination, like acute like absence of deep tendon reflex or cervical lymphadenopathy. So the question here is, what is the most likely diagnosis? Acute myeloid, cytomegalo infection, diphtheria, gradual fever, cryptococcal tonsillitis. So someone here saying is B, C, B, C, B. So here we are going for the answer. So here it is. It's diphtheria. It's diphtheria. The thing is, you have to keep in mind fever plus several areas of exudates on her pharynx and extension of cervical lymph node. So which one is the primary of diphtheria? Do you think the deep tendon reflex will come first, or the source and the lymphadenopathy? So this time it's for bamboo question. Be careful about that. They just give you a very bad U-turn for the absence of deep reflex. But in the first, they are giving you all the common features of diphtheria, like exudate in the pharynx and cervical lymphadenopathy with fever. Be careful about that. Sore throat, and you go for the diphtheria. Someone is talking about the Epstein-Barr virus. Okay, the thing is, in infectious mononucleosis or Epstein-Barr virus, they will always give you one important clue. The patient is on antibiotic. Be careful about that. Is there anywhere they're saying that this patient is on antibiotic or something? This one is a very common question in the exam. So be careful about it. Which one you will go first? Okay. First exudate, then rest of the things. Yeah, it's a bamboo, sorry. Oh, someone says if Epstein-Barr virus was in the options. Yes, yes, I previously told that for Epstein-Barr virus, one thing, be careful about that. They will always tell you the patient is on treatment. Okay, be careful about that. That's why I told that things. They will always tell you the patient is on treatment. Because how we will differentiate all of these things? Okay, so be careful about it. Try to find this patient is on treatment or not. So here we are going for our last question. Probably it's not going to be a bamboo, but sorry to say this one is a bamboo question. Here we are getting the three for diphtheria. Now we are going for our last question. Which one of the following concerning Corynebacterium diphtheria is correct? Again, we are getting the question of diphtheria causes skin infection. The thing is, they are talking about the correct. Which one is correct? Which one is not? Causes skin infection. Infection is often complicated by mycobacterial fibrosis after the recovery of severe infection is most unlikely to cause infection in an individual with positive sick test, might stain. Toxin is better absorbed through the nasal than the laryngeal mucus. So, what do you think is the answer? This one, again, we have to use those things, process of elimination type of things. Which one is the correct? Everyone saying is B. Infection is often complicated by mycobacterial fibrosis after recovery from severe infection. Okay, we are going for it. We are going for it. When everyone is saying it's B, it must be B. No way out. Okay? It must be B, B, B. Someone saying it's double B, but in the question there is only one B. So there is no double B or BB. Okay? Infection is often complicated by the mycobacterial fibrosis. We all know that. So when we get this type of things, this one is very much easy for us because we don't need the process of elimination here because this will be the answer. So why should we go through the next 3 or 4 questions? But yes, we have to go for last 3, 4 options. Then we'll stop it. Okay. So the answer here is the famous B. Okay, with that, we are close to into our class. Hopefully, you will like that class. If you have any question, you can ask, or what do you know, what do you want to know, you can say that. And anything you want to add, you can also say that, please, doctor, add this or that, because we are introducing it from the very first time. So in the file, where there will be 2 or 3 confusion. I'm really sorry for this, but we'll try to figure it out. So hopefully this is for today's class. We'll meet in the next day, and that time we will complete those things. Thank you.